as you can see per the instructions listed here in the Q&A or chat panel text box. I will be giving our speakers a 2-minute warning so that we allow 5 minutes at the end of each session for questions to be discussed by the speakers. Finally, the last slide of each of today's presentations includes a QR code that's readable with an app on your cell phone. Please use the code to access and complete the survey that will also result in the award of your continuing education credit for each hour or component of the continuing education program. Next. So we have a number of presenters today. I just want to indicate that any disclosures made by the presenters are indicated in the program as you see here. And then I'd also like to note that, next slide. Just as a reminder, you will need to complete the SurveyMonkey evaluation in order to receive e-credit. Continuing medical education credit is being awarded. Next slide. So before beginning today's with today's speakers, I just want to make some very brief opening remarks for our program today. On behalf of President Kirk Calhoun and Dean Gerald Ledlow of the School of Community and Rural Health here at UT Health Science Center in Tyler, this is a biannual event for the campus here, and so I'm so delighted to have a group of nationally recognized speakers combined with the senior residents from the 2 accredited occupational medicine residency in the state of Texas, providing a very excellent lineup for today's program. We normally have a much longer in-person program, but given the circumstances, have elected to shorten this to a virtual program this morning, and are pleased to announce that we've had over 200 registrants who will be participating from across, as well as multiple other states and international locations, including one of our Association of Occupational and Environmental Clinic Partners, international sister clinics. This is a particularly special year in that we were planning to invite TexCom members to Tyler for their annual educational meeting, usually held in conjunction with the Texas Medical Association's TexMed conference. However, said meeting was in conflict with the American Occupational Health Conference, so it was long ago decided to combine the programs with this Emerging Issues Conference, and naturally, all of this changed for an in-person conference with COVID. Nonetheless, it's been a privilege to work with our co-sponsors from TexCom and UT Health Science Center at Houston School of Public Health, and our 2 health science centers are home to two of NIOSH's center programs that I mentioned earlier, who are co-sponsors for today. This is also a special occasion to commemorate and celebrate the 50th anniversary of NIOSH, the 30th anniversary of TIOSH, and during today's conference breaks, you'll be seeing displayed a number of photographs from 2016 Emerging Issues Conference and Resident Commencement. And I'll draw your particular attention to that was a time when Dr. John Howard from NIOSH was on our campus, and Mr. Earl Daughter, a renowned occupational photojournalist, was here on our campus as well. I do want to take a quick moment to thank the departmental staff in Houston and Tyler, as well as our IT departments for all of their efforts to make this a successful and smooth meeting today. And I'd like to recognize and give a special shout out to Amanda Watkins, Sarah Lang, Meredith Burks, Michelle McDaniel, and Josh Pezos today for all their assistance in making this successful. We hope you enjoy today's program, and with that, I'd like to begin with our first speaker of the day, Dr. Ketki Patel. Dr. Patel is currently a senior epidemiologist at the Department of State Health Services Environmental Surveillance and Toxicology Branch. She leads the Texas state-based Occupational Safety and Health Surveillance Program and also serves as an environmental and occupational epidemiology subject matter expert in the Texas State Medical Operations Command and post-disasters, and is a faculty member for the DSHS Preventive Medicine Residency Program as well. She has over 10 years of experience in public health epi research and surveillance, has her medical degree in general medicine, a master of public health degree in environmental, agricultural, and occupational health, and a doctor of philosophy and epidemiology, both of those from the University of Nebraska Medical Center. I'm so delighted today that she's going to come and speak to us about a very important topic, emerging issues topic relative to pneumoconiosis in Texas. So Dr. Patel, I will turn the mic and platform over to you.
Thank you, Dr. Levine, for a generous introduction. Can you all hear me? Just checking.
Is Dr. Patel unmuted?
Dr. Levine, can you hear me? Good morning, everybody. If anybody can hear me, can you just respond yes in a chat box so I can proceed? Thank you so much. Good morning, everyone, once again. And Dr. Thank you for giving me an opportunity to share some of our experiences working in occupational safety and health in Texas, and also discuss some of the emerging issues that we have been experiencing in Texas in recent years. With that, I would like to begin the presentation. In today's talk, I will be giving a quick overview of what occupational surveillance is, as some of you may or may not have that experience. Second, I'll give you a quick snapshot of what we do here in our home-based Texas for population-based occupational health surveillance. And then I'll walk you through some of the unique challenges and opportunities for conducting surveillance and research in this discipline, and some of the next steps and road forward for all of us to collaborate on in addressing some of these challenges in occupational safety. Next slide, please. So what is occupational safety and health surveillance? Let's take a first look at what public health surveillance is, because that's the core component of any surveillance that we conduct for health conditions, exposures, hazards, etc. So public health surveillance is defined as systematic, ongoing collection, management, analysis, and interpretation of data, followed by dissemination of these data to public health programs to stimulate public health action. Now, I know that's a lot of words, but in short, what public health surveillance is, we're using data to create meaningful interventions and public health actions to prevent and protect the health of our citizens. Next slide, please. What is an occupational injury or illness? Oftentimes I get asked this question. And so it's really difficult to sometimes, separate something from a work-related exposure to a not. That is why BLS has this definition that you can see on your screen right now, and they phrase an occupational injury and illness as an event or exposure in the work environment, either caused or contributed to the resulting condition, or significantly aggravated because of occupational exposure or hazard at workplace. Next slide, please. So why does it matter? Why do we really need to care about occupational safety and health? In 2019, more than 163 million people of the age of 16 years and above in the United States worked in different jobs. American Time Use Survey estimates about 1/3 of our adult life is spent earning our living. So which is why you are constantly being exposed at so many levels of stressors, exposures, and hazards at different workplaces and job sites. Occupational injuries and illnesses can incur substantial costs, including medical care costs And if you end up having a severe injury or an illness, it can result into a lifetime disability as well as fatalities. Next slide, please. Let's look at some quick fast facts. Now, I know that you're looking at your screen and going, why is it still showing 2016? So let me tell you, some of these data are extracted from the national level data sources, and a lot of them have at least a 2 to 3 year lag time in some of the data that becomes available. So if you are interested in some of the most recent statistics, please reach out to us and we may be able to pull it for you. But for now, let's take a look at what our Texas workforce looks like. We had about roughly around 12.5 million employed people in the year 2016, of which about 55% were men and 44% were women. And 94% of these individuals were in the age group of 18 to 64 years of age. And 36% of the workforce in our Texas constituted of Hispanic race and ethnicity. Next slide, please. Coming down to what are some of the outcomes of work-related injuries in Texas, we had about close to 500 plus fatalities because of a work-related exposure hazard or an incident in the year 2016, which brings us to about a 4.4 fatality rate among 100,000 full-time workers in Texas. Next slide, please. Coming on to some of the less severe injuries that may result, in hospitalizations or disabilities, that constituted about 185,000 injuries and illnesses that were reported by employers in Texas in 2016. Now, let me tell you, a lot of this information is coming from employer-based surveys that the Department of Labor Bureau of Statistics conducts on an annual basis, and there is a severe underreporting. So this is only the tip of the iceberg that you're, seeing on your screen right now. Next slide, please. In the year 2016, Texas workers' compensation paid about $1.4 billion in workers' compensation benefits. Now, as many of you may know, Texas is one of the only opt-out states in the country. What that actually means is that employers do have the option to opt out of a state workers' compensation program and provide their own employee health services and coverage. Now, that said, there is still about an 80% coverage for the Texas workforce in some form of a workforce injury and illness benefits program that they have. But there is still about 20% of our workforce that's not covered by any of these sort of compensation programs if they were to incur injury or illness at work. Next slide, please. Now, why conduct occupational health surveillance? We looked at all of these statistics. So as we learn from our case definition of what public health surveillance means, it means you will need to keep track of some of these occupational health exposures and conditions, so that way we're able to monitor trends over time, identify any new emerging issues and patterns in some of the hazards that affect our workforce. We need to also be able to identify some of the high-risk worker populations, so we are able to allocate necessary resources and interventions to prevent occupational injuries and illnesses in these working populations. Next slide, please. So let us take a quick step back and look at one of the history of occupational safety and health in the United States. So as many of you know, back in 1970, the US Constitution implemented the Occupational Safety and Health Act, which resulted in creation of two major agencies. One was the US Occupational Safety and Health Administration, as many of us know it as OSHA. And the second one is the National Institute for Occupational Safety and Health, which is within the Center for Disease and Control. Often we call it as NIOSH in short. The key difference between these two agents is OSHA is regulatory, versus NIOSH is more in terms of research, surveillance, and recommendations for prevention activities, and does not implement any enforcement actions. Next slide, please. Can we take a slide back, please? Thank you. So let me give you a quick snapshot of how occupational health surveillance occurs in the US before we take a deeper dive into just the state of Texas. So as I mentioned, the creation of two agencies, OSHA does conduct some form of the surveillance activities through their routine inspections, and a lot of the data that they collect is also publicly available for researchers to take a further dive into it and analyze some of the hazardous issues that OSHA identifies during their inspections at different work sites. However, NIOSH currently funds several U.S. states and academic centers, one of which is, the Southwest Center for Agricultural Safety and Health at UT Tyler, to conduct, occupational health surveillance, research, and prevention activities. The U.S. Bureau of Labor Statistics also conducts state and national level occupational health surveillance. So when I showed you the statistics of those fatalities and non-fatal injuries in occupational illness, those technically come from surveillance systems that are set up by the Bureau of Labor Statistics. Next slide, please. As you can see on the screen here is all the states that are shaded in orange color are the states that currently receive some level of funding from the National Institute for Occupational Safety and Health to conduct state-based occupational health surveillance activities. Now, there are a lot of different levels of fundings that are provided by NIOSH in each different state. Some of the states have, higher level of funding because they may be doing some expanded level of activities, and some of them may be, really new programs in the state that may be, conducting basic surveillance activities. And because of that, there are a tiered level of states, the way they categorize as fundamental, which is basic. There are a level of occupational health indicators, and we'll take a look at later in this presentation. And that's what the fundamental program does. And then we have a fundamental plus program who investigates some of the most priority conditions in their respective states, in addition to monitoring some of those occupational health indicators. And then we have, a very handful of states that are expanded who have a long-standing history of conducting occupational health surveillance activities. And they will also be working with the Workers' Comp Division to take, further look into some of the issues that may be pertinent to their own states. So as you can see on this slide, Texas is a fundamental plus program, which means that we do basic surveillance activities, but we also do surveillance activities for some of the emerging topics and high priority issues in the state of Texas. Next slide, please. So we're currently housed at the Texas Department of State Health Services. And going forward in the presentation, I will be using the acronym OHS, which is a short form for State-Based Occupational Safety and Health Surveillance Program. We're housed in the Environmental Surveillance and Toxicology branch and have a long-standing history of serving Texans back since the 1980s, and we'll look in the next few slides from now. Next slide, please. So this slide here is giving you a very quick background of how this program has evolved over the last 3 decades in the state of Texas. Texas was one of the states in the entire country to make 4 occupational conditions reportable to the Department of Health ever since 1985. As you can see on the screen, since 1986, there are 4 occupational conditions that are reportable to Texas Department of State Health Services. The first one being adult blood lead levels. The second one is acute occupational pesticide poisoning. And then are the 2 occupational lung conditions, silicosis and asbestosis. We'll take a further dive into this presentation for each of these reportable conditions and see what exactly we do in form of surveillance for these conditions. Since 1986 to 2005, there was a separate mechanism of funding that the program received through NIOSH, and it was called as the Sensor Program. And NIOSH changed some of their extramural funding programs and wanted to develop state capacity for more expanded activities for occupational health surveillance and research, and started providing these state-based or population health-based surveillance grants to state health agencies to conduct these activities. So we have currently about 15 years plus of funding support ever since 1996. We have been supported through NIOSH to conduct these activities in the state of Texas. Next slide, please. So let's take a look at the very first reportable condition that I mentioned about, which is adult blood lead epidemiology and surveillance. Now, we've been collecting data from laboratories and physicians about children and adults who test positive for blood lead. Now, any level of lead is not good in your blood system, so there is no threshold for that. Even, anything as soon as it's recognized in your blood test, it gets reported through electronic laboratory system to Department of State Health Services. Over the years, we've obviously gone from paper to electronic-based surveillance with the aid of technology. So that has been quite helpful to keep up with, the population of Texas. Currently, this activity is conducted in partnership with the Blood Lead Surveillance Branch, which is housed within the Texas Department of State Health Services. They're the ones who primarily collect all of the data and turn the data, and the Occupational Health Surveillance Program provides additional support if there is a need for conducting, worksite investigations or additional follow-up for workplace exposures involving lead. Currently, staff also conducts activities for adult blood lead levels 5 and above. As you know, we have a really large population to cater and only limited resources. So we have built a level of threshold for different types of responses. So for example, if somebody has a blood lead level of 5 and above, we're going to send them a notification letter to the patient and then let them know that, this is what they've tested for. And then we'll provide them some education and outreach materials on how they can prevent exposures. If they are about the level of 10 and above, then we would be making a phone call follow-up and then asking them about some of these exposures. And then these data are then submitted to NIOSH on an annual basis. Next slide, please. Another condition that has been under surveillance is occupational pesticide exposures. And as many of you know, Texas has a really large agricultural economy with rural populations, which are really hard to reach and have really limited resources in terms of medical care and medical facilities available to them. Currently, all physicians and laboratories are required to report any form of occupational exposure to the Texas Department of State Health Services. We also not only collect data on conventional pesticide exposures that are insecticides, herbicides, fungicides, but we also include disinfectants. As many of you know, there are a wide variety of disinfectants that EPA, the U.S. Environmental Protection Agency, classifies as pesticides. And so our surveillance system has been capturing these data since the year 1986. Currently, some of the bigger challenges that we face in pesticide exposure surveillance is a lot of the time these exposures occur among either farm worker populations or service occupations such as housekeeping, maintenance, landscaping workers, as well as housekeeping workers. And a lot of you know some of these individuals are really hard to reach worker populations. And they have a lot of the other hesitations in terms of reporting their exposures or even seeking medical care for some of these exposures. And oftentimes, some of these exposures may not be as severe and may not end up in hospitalizations and are not captured by our surveillance systems. The majority of our data source for pesticide exposure surveillance comes through a network of Texas Poison Control Centers. Currently, we have about 6 of them. And so oftentimes nurses, ERs, or even individuals, when they get exposed to either a disinfectant or pesticide, will be reaching out to poison centers to seek more information about management of these cases. And we use that data, real-time data, to track some of these exposures in working populations. Next slide, please. The next 2 reportable conditions in Texas are silicosis and asbestosis. As we know, asbestos fibers are really, really microscopic elements. And then asbestos is a latent disease that takes a long period of time and a cumulative exposure of years to develop a lung pathology. As we can see here, this definition of asbestos is a chronic fibrotic lung disease, which results from long-term inhalation of respirable asbestosis fibers, which eventually, once you get asbestosis, there is no cure for it. So either you would end up with some form of an obstructive lung disease or a restrictive lung disease. A lot of times we see some other comorbidities that exist with asbestosis, which is why sometimes it may not be purely restrictive. And eventually leading you to disability and affecting your work and general life. Next, please. And the next is silicosis, which is not only in existing, but some of the emerging issues in select industries in the state of Texas. As you all know, silicosis is a respiratory disease, again, caused by inhalation over a long period of time when somebody is inhaling crystalline silica dust over their duration of work history. However, what we are observing now is that trend is changing. It's not any longer a disease where somebody had an exposure and then 20, 30 years after they will be developing the lung pathology. What we're observing is more younger and younger population contracting this disease and manifesting symptoms of severe disability and including death. And that in part is because of some of the unique industries that have evolved in the last couple of decades that have resulted in some of these problems. And a lot of these lung conditions bring a lot of the other comorbidities along with it, such as tuberculosis, malnutrition, and other obstructive lung diseases along with it. Next slide, please. Currently in the state of Texas, we primarily rely on physician reporting of asbestosis and silicosis. And given that I have this platform, I would really want to encourage all of my physician colleagues there as to, if you are ever encountering these cases, please report it to Texas Department of State Health Services. And this is because this is one of the heavily underreported condition, not just in the state of Texas, but in the entire country. And some of the other data sources that we try to look into to identify asbestosis and silicosis cases among our populations are death certificates and inpatient hospital discharges. And we do, on an annual basis, keep track of these data and calculate a set of occupational health indicators, which we'll take a look at in a couple slides from now. And we also conduct special investigations for each of these items or reportable conditions that I've mentioned in the last couple of minutes, including worksite visits and additional investigations with the help of NIOSH. And we'll look towards that in the next couple of slides. Next slide, please. I've been talking about occupational health indicators. There are about more than 24 indicators that we calculate for different occupational health conditions, exposures, hazards, interventions, as well as from economic perspective in looking at the workforce data on an annual basis. We've been collecting this data since 2005. Currently, the data is available upon request, and we also release annual reports and submit these reports also to NIOSH, our funding agency. But we also are currently in the process of developing interactive dashboards, and we have some really great epidemiologists in-house at DSHS who are quite tech savvy and really good at data visualization. So look forward to some of those dashboards in the near future. So that way you'll be able to take a detailed look at some of these indicators. We use approximately more than 10 to 12 different state and national level data sources for these conditions. Let me give you a quick example. Some of the conditions that we're currently looking at, not just fatalities and non-fatal injuries, but we're also looking at musculoskeletal disorders, carpal tunnel syndrome, different pneumoconiosis, not just silicosis and asbestosis, but the whole spectrum of it. All different levels of blood lead exposures among adults. We're also looking at low back injuries and disorders and hospitalizations resulting from it. We're looking at burns, including chemical burns. We're looking at heat-related illnesses, particularly those that require hospitalizations and ED visits. We're also looking at occupational eye injuries, as that we have seen a quite surge in the last few decades on eye-related injuries at different workplaces. And we're also look at the workers' compensation data in terms of how much did we workers' comp paid for a specific type of injury and illnesses. So that way we can estimate the economic burden that some of these occupational conditions have on our society. Next slide, please. The program currently not only just conducts surveillance activities, but we also do a lot of education and outreach. We do have an in-house capacity to develop some education materials. So one of the recent accomplishments that we have and is currently airing is a radio campaign for all outdoor workers in the state of Texas. We've been airing that radio message for heat prevention, heat-related illness prevention, and increasing awareness among workers. Now you may know that a lot of people are not working outdoors right now because of COVID-19, but we still have the heat-related exposures in some of those people who can't work from home and are working outdoors in essential jobs, including some of them who are out there doing testing. So we're currently running a radio campaign, an awareness campaign on heat-related illnesses. So that's one of our accomplishments. We also aid NIOSH on special investigations on rare exposures of public health significance, and we'll take a quick snapshot of that in the next few slides from now. We also provide technical consultations and provide epidemiologic support within the SHS to other program areas and divisions, as well as external to DSHS and other agencies as well. Currently, our program area has been massively supporting different level of activities related to COVID-19, ranging from purchasing and vetting the personal protective equipment that the state purchases for the state of Texas, to helping conduct site visits at workplaces and facility assessments, which some of you may have participated with us in the last couple weeks in meat processing plants and so forth, and also helping provide guidance documents for working populations in relation to prevention of COVID-19. In the past, we've also extensively participated in some of the other response activities for natural disasters, such as hurricanes, industrial, and man-made disasters, such as industrial fires. We also collaborate quite often with academic universities and other institutions and nonprofit. And Dr. Levine is one of our great collaborators and longstanding collaborators for the occupational health program. Next slide, please. So over the next few minutes, I am going to give you a flavor of what are some of the emerging and existing issues related to pesticide poisoning. And some of these issues are not only just emerging or re-emerging, as you may say, but also challenging because they're so unique. One is, as I mentioned, a lot of these exposures are happening among hard to reach and vulnerable populations, for example, farm workers. And that, poses a massive barrier, not only in terms of surveillance, but also in terms of prevention. Let's say we, collected some data and were able to develop some form of education and outreach intervention for them. Even reaching out to them is quite a challenge. We were able to, talk a lot about those challenges and some of the unique solutions to those challenges in partnership with other states. And we released that report back in 2017, as you can see on the screen. Another is oftentimes a lot of our emergency responders, first responders, not just EMS folks or firefighters, but also law enforcement officers get exposed to different kinds of pesticides when they're responding to an incident. And not long ago, we had such an incident in Texas where we had emergency responders exposed to pesticides, one, because they weren't aware and of what the exposure was about. And second of all, also because we always see that, these are the people, these are our heroes who have a great spirit of service, and they always, consider the people before themselves. And, they would fail to wear some of these PPE, even if it is available to them, because they would be like, okay, no, I want to help somebody first, and then I'll take care of myself, which kind of results in, exposures to some of these hazards and exposures on the job, including some of them requiring, further medical care for these exposures. And last but not the least is also a lot of time residential places and pesticide applicators get exposed because maybe, people are not posting notifications if somebody or a place has been treated with pesticide and so forth. And one of the common exposures that has been occurring is in, structural settings, workplaces, offices, buildings, residential settings, such as total release foggers. We've seen a lot of exposures resulting from restricted use pesticides. When I mean restricted use is those are pesticides that should be only made available and used by certified, pesticide applicators. But a lot of times what we are observing is people may not be trained or certified enough or equipped enough with, the knowledge of how to handle and dispose these, products. And while either using them, they come in contact with it, or they misapply some of these products, and that may result in severe illnesses. Next slide, please. Recently, we were able to look at the last 10 years of data, and we've published a report looking at occupational pesticide poisonings. And not to our surprise, we learned that more than 50% of these exposures are happening because of exposure to disinfectants, but not conventional pesticides. And the occupational groups that we're most concerned about are not just healthcare workers, but also other workers or support workers that work in different healthcare settings and non-healthcare settings that may be involved in cleaning, sanitation work, and maintenance work, etc. Next slide, please. Next slide, please. Next. And as Dr. Levine was mentioning, pneumoconiosis has been not only just a long-standing issue, but we are seeing some other issues emerging from pneumoconiosis. One of which is in engineered stone countertop fabrication. Texas had the very first case in the US in 2014, where an individual was exposed to silica and developed silicosis in a really short period of time. And then over a period of time, there were some additional reports too. But fast forwarded to last year, we saw an outbreak of silicosis among an engineered stone countertop manufacturing facility in the state of Texas. And while further investigating, we found out that there were several other similar outbreak and cases in other states as well. And we were able to dive deeper into some of the issues associated with it and see how these workplaces are handling some of the exposure control measures, how educated are workers in terms of using the PPE, what are the things available to them or what are the things not available to them, and also trying to understand what are some of the issues why we are seeing the disease onset so early and in really young population. We've had individuals that have developed disease with just 1 year of exposure to respirable crystalline silica. And, barely some of them were, 30 years of age, and there were, a couple of fatalities in the state of California because of this. So it is a serious issue that needs to be addressed, sooner than later. Next slide, please. One of the big wins for us as a collective effort with NIOSH, OSHA, as well as all of the states that partnered with us on this investigation was we were able to reinstate the national emphasis program for silica so that way, more and more inspections could be conducted and more work sets could be evaluated for some of these exposures occurring due to silica dust in these populations. Next slide, please. To sum it up, some of the emerging and priority areas for occupational health surveillance in the state of Texas are vulnerable workforce populations, transportation incident-related injuries and fatalities. That's our top one cause of occupational fatalities is transportation-related incidents. Now, third is pesticide and other hazardous exposures, as we've looked in the previous slides. Heat-related illnesses. We are located in a very unique environment, and with the growing environmental, temperatures in longer summers, what we are also observing is heat-related illnesses in people working outdoors. But we're also observing not only some of these heat stress in outdoor workforce, but also in some of the indoor workforce that may be exposed to some of these hazards. Another issue that is emerging is occupational noise-induced hearing loss. And there is not yet a robust surveillance system for occupational noise-induced hearing loss, neither in any of the states or nationally. And there aren't many great data sources that provide you this information. So that is definitely an area that needs to be further explored. Other is, as we have been discussing, we've spent 1/3 of our lives at working and earning our wages, and that adds to a lot of different kinds of stressors and fatigue, and affecting our mental health and contributing to a lot of other chronic conditions. So work-related stress is not only just an existing but an emerging issue that needs to be looked upon further. And given the current circumstances, as we all know, a lot of the population have lost their jobs and are at an added pressure because of the current ongoing pandemic. Some of these issues are going to need more attention than it has in the past. And last but not the least, we are seeing a lot of different types of natural and non-natural man-made disasters occurring in the last few decades, which really requires us to work on our disaster preparedness and emergency response, and also making sure that the people who are, serving in response and recovery activities are, educated as well as trained properly, so that way they can take care of themselves while they are helping others. Next slide, please. Next slide. Next slide. Thank you. Some of the changing workplaces add additional challenges. As we know, the workplaces back in the 70s and 80s and 90s are no longer the same. The workforce is changing. We have much more diverse workforce now. The work is rapidly evolving. A lot of the workplaces are moving towards gig economy, contract workforce, non-standard work arrangements, and precarious employment, which add additional challenges when we're trying to do, surveillance, research, and prevention activities in these working populations. Oftentimes, we encounter language barriers as a major issue that employers face, as well as us as health departments, in reaching out to the communities, because oftentimes, the employers may be just, educating their entire workforce or releasing things in English or just Spanish, but they may have, much more diverse, workforce who may not be speaking either of these languages, and oftentimes, are exposed to these hazardous situations because they're not able to recognize it and understand some of these educational materials. Next slide, please. Underreporting and underrecording. As I have been, pointing it out throughout my talk today, underreporting and underrecording is not just by, healthcare providers, but it's also by employers and employees. And this is because a lot of times people are concerned of data confidentiality, privacy, and also, repercussions of, and other consequences that may result if, an employee was to report an injury on an illness. A lot of them are, refugees or recent immigrants, who may be always at a fear of retaliation from the employer in some of these industries that we've talked about. And that makes it really difficult to conduct surveillance activities. Another, as I've been mentioning, are hard to reach worker population. It's just really difficult, not physically to reach out to them, but also, virtually to be able to convey some of our messages, public health messages to these working populations. And again, cultural and language barriers are something that are always going to be a challenge, not just with occupational health, but public health in general. Next slide, please. Other challenges, that we're currently experiencing are access to quality data for occupational health information. As you all may know, a lot of times when you see a patient, you're not asking a lot about their work history, are we? But and that is why it's again important to collect work information when you're seeing a patient, because there may be certain things or triggers to somebody's current ailment which we're not able to identify because we don't know what they're working in and where they're working. And which is why there is a national push to educate our fellow physicians and other healthcare provider community to start looking for some of the answers while you're taking history from your patients, about certain health conditions. Another is limited exposure surveillance data. Now, a lot of times, when we see patients and we have these reportable conditions, it's okay when somebody develops a health condition, but it's the exposure that happens before a health condition has not been captured quite well, because it's really hard to conduct surveillance for some of these exposures that may be happening at workplace. So unless an employer was conducting surveillance for some of these exposures, it's really hard, for a health department, if you will, to identify some of these exposures that may be happening, on the job, and capture them, in some of these surveillance systems. And last but not the least, there's limited resources, including the manpower and capacity of trained professionals in occupational safety and health. Next slide, please. Next slide. Thank you. And so, what are some of the possible solutions? What can we do about addressing some of these challenges that we have been talking for the last 30 minutes? One is strategic partnerships. It is always going to take a village, if we are able to, if you really want to, be able to maintain safe workplaces. We will need more and more strategic partnerships, interdisciplinary collaborations to enhance surveillance activities as well as prevention capacities. And these partnerships need to happen not just within among different state agencies, but also between state agencies and other community partners, such as nonprofit organizations, academic institutions, etc. Next slide, please. And another item is, we collect a lot of different data sources, not just the health department, but there are several other sources of data. Not many of them I have not even mentioned in this presentation. And a lot of this information currently, stays where it's collected, and we still don't have that enhanced capacity to look at this data and convert it into meaningful messages that can be used for public health actions. And so we need to really improve our surveillance processes for collecting quality data, and also amp up our capacity in data analytics, so that way we are able to timely analyze this data and share the data with the decision makers, with healthcare providers, and the community, for preventing some of these conditions. Next, please. And last but not the least is education and outreach. If we're looking at all of these data but are not able to use it for public health actions, that's no good at all. We also need to be thinking about innovative methods of education and outreach. I think those days of print materials and fact sheets and long booklets and reports are long gone, because these days people really need something fast and quick that they can see on their mobile screen, or just take a quick look at on a video clip or something like that. So we really need to tap into and explore some of the innovative ways to reach to this population. What are the best ways that they would want the messages to be communicated to them? And this is not just for working workers, but also for even employers. Like, what are some of the key messages that you can give them in a very quick manner and easy to understand? So one way forward is tapping into creative and digital media spaces, which technically means is also trying to find collaborations with our media partners in the community that can help us get the message to these worker populations and employers and communities. Next slide, please. And then last but not the least is building our workforce capacity in healthcare, public health, and specifically in occupational safety and health. In fact, if you are interested, we also keep a track of how many occupational health and safety professionals are there in the state of Texas. So that way we're able to identify, some of those partners. So if we look at that over the last couple of decades, there aren't many trained occupational safety and health professional, let alone just people with a healthcare background, to be able to identify some of these disease conditions and be able to prevent them among communities. Next. And with that, I would like to close the presentation. And once again, thank you all for being a wonderful audience. Thank you for having me. And what you can see on the screen is my contact information. Please do not hesitate to contact me either via email or on my cell phone anytime. If you have any other feedback, suggestions, ideas for collaboration, or additional items that you would like to convey to us, please feel free to reach out. Thank you.
Well, thank you, Dr. Patel, for that very current and informative presentation regarding surveillance in Texas. Some great work being done, some exciting things being done. If you would like to, if you're willing to tap on your video button, your video can come up if you want to share your video screen as we present you with a couple of questions.
Sure.
In the meantime, in a minute, I just want to remind everyone to please be sure to use your app on the QR code for completing your evaluation. We have a couple of questions, Dr. Patel. One, why, if you could expound on some of the reasons you find it difficult to reach out to vulnerable workers. One important question.
Great, and it's actually $1 million question that we're really struggling with. So I'll try to answer as best possible, but I'll also encourage any feedback or some brilliant ideas that our audience may have for us in terms of reaching out to these vulnerable populations. I guess the number one issue is not just their physical location of where some of these populations are located, but it's also about the demographics of these populations. For example, some of these vulnerable populations are hard to reach worker populations are in specific industries. And we're talking about some of these agricultural and manufacturing industry that employs, blue collar workers. A lot of these individuals are, working at minimum wages. They are, maybe recent immigrants or refugee populations. They may also may not have the level of not just health literacy, but overall educational attainment to understand some of the issues and also the health and safety messages that are being put out there. And some of these individuals, just given their background and the culture that we come from, are just really not open to having conversations about issues just because of the fear of retaliation from employers. And it's not about we're trying to pinpoint that one employer is bad than the other, or one industry is really terrible at working with their workforce. I mean, obviously there may be some bad actors, but not the entire industry is bad. But because of these select examples, there has been a fear among individuals that, oh, if I'm going to report that something happened to me at work, then maybe I'm going to lose my job. Or, oh, if I talk about something like this, then maybe they'll come back at me and maybe not pay me. Or, oh, maybe if these are like recent immigrants or refugee communities, they would already have all of these other issues or baggage that they carry, and maybe hesitant to not just talk to the employers, but even to the healthcare providers. And last but not the least, a lot of these individuals, as I mentioned, if they're not having an employer-provided insurance or not, having other form of private insurance coverage, they don't have the capacity to go to a healthcare facility and seek care for some of their conditions. And it may be not just limiting to occupational exposures; it can be beyond that. They may be having diabetes, but they're not able to control it just because they don't have, the insurance or the other resources to help take care of it. And in addition to that, a lot of times also we're seeing that some of these populations are in rural locations, and Texas is no foreign to it because we're a really large state with some really large urban metropolitan complexes, versus, some parts of our state that are really hard to reach geographically, and they don't have great, medical access in some of those locations, which may pose, challenges to some of these working populations. In fact, recently we were looking at, some of the outbreaks in meatpacking facilities, and we were learning that, people are traveling across different counties to come to work. They're even crossing, state borders to come to work. So, these kind of add a lot of the challenges in terms of, reaching out to these people for any kind of interventions.
So certainly, thank you. That's for a very broad answer, a number of challenges there. So I think that's all the time we have. We did have one other question, but I think we're going to have to move on just to stay on tap today. Again, I want to thank you so much for participating today. It's really been a privilege to be able to work with you, and certainly to have you come and speak to the group. We do hope you'll stay during the rest of the conference, but so delighted to have you.
Thank you so much.
I want to go ahead and let others know the QR code is up. We're actually going into our break now. And I would ask that everyone please return promptly at 9:50 when we'll begin with our ethics panel session. Well, we're getting ready to resume today's virtual conference with our next presentation entitled Occupational Health Challenges in Agricultural and Rural Communities during COVID-19. There will be a moderator and 3 panelists. I'm going to go ahead and make introductions as we're queuing up the slides here. Our moderator today is going to be Dr. Vanessa Casanova, who is Associate Professor of Occupational and Environmental Health Sciences. Dr. Casanova has a Bachelor's in International Studies from the University of Alabama, and Master's in Rural Sociology and PhD in Forestry from Auburn University. And her postgraduate training is in fields of labor studies and public health. She actually joined UT Health Science Center in Tyler in 2013 with her primary focus in the Southwest Ag Center, but much of her effort dedicated to teaching, research, and service to the university. She is also a PI and director for the NIOSH-funded Southwest Center for Agricultural Health, Injury Prevention, and Education, which serves U.S. Public Health Region 6 to do a myriad of work in the AFF fields, as you heard from Dr. Patel earlier. Our second participant is going to be Amber Baker, who is the clinic nurse manager for the Occupational and Employee Health Clinic here at UT Health Science Center in the North Campus clinical operations. She has worked with our team for 7 years in caring for employees and patients and managing clinic activities, and has been a participant in several initiatives related to the Ag Center and other occupational health activities, particularly most recently relative to COVID-19. And then certainly certainly last but not least by any stretch is Dr. Ann Carruth, who is actually Dean of Nursing and Sciences and Professor at Southeastern Louisiana University. Dr. Carruth completed her DNS at Louisiana State University Health Sciences Center, her master's at the University of Mississippi. She is has numerous honors and awards with a wide variety of research interests pertaining to culture of hospital environments and impact on retention of nurses, community public health, farm worker health and safety, and for me, as a longstanding mentor and collaborator, she has been engaged with some work that I've done over several years in commercial fishing. So it's a delight to have all 3 of these colleagues and esteemed experts in this area. I do want to remind everyone that this particular topic is available for ethics credit for the physicians who are claiming ethics credit, ethics CME credit. So with that, I'm going to turn this over to the moderator, Dr. Casanova.
Good morning. Good morning, everyone. I hope you can hear me. It looks like I'm unmuted, so I'm just going to proceed. This session is entitled Occupational Health Challenges in Agricultural and Rural Communities During COVID-19. I'm glad to have everyone here. Good to see that we have so many participants online. Fantastic participation. So I'll just start us off with a little story here. While many Americans are working from home, many of you probably know that farm workers have continued laboring in fields. Farm workers have been designated essential workers by the Department of Homeland Security, and they continue to report to work daily. And working outside puts them at less risk than if they were in a meat packing facility, for example. Labor advocates say these workers are very vulnerable to the virus because they often work in close proximity, live in cramped communal housing conditions, and commute to the fields in crowded vans and buses that make social distancing measures that have been suggested by the CDC very difficult, if not impossible, to adhere to. Many also have pre-existing conditions, and some have no sick leave or health insurance. The pandemic puts additional strain on a community historically overworked and underrepresented. These essential workers will keep shelves stocked of fresh and processed produce, proteins, and the fiber demanded by the public during this unprecedented public health emergency. Our food supply chain is quite resilient. However, ethical considerations here. The public is rightly concerned with the food supply chain, but how are we protecting this workforce from illness? And not just from COVID-19. For example, task for many hired farm workers is to apply herbicides and pesticides. Anyone who handles or assists with the application of pesticides is required to use filtering masks, such as something as good as an N or better, when they work with products which are lethal or toxic if inhaled, or if risk assessments identify other issues that need to be addressed. So what should farmers and farm workers do? The communities we serve, whether they are agricultural and rural communities or communities of healthcare workers and trainees, are faced with unique barriers, challenges, and ethical considerations during this pandemic. Today we have two presenters, both nurses by training, as you've heard. Amber Baker is our clinical nurse manager for the OHC here on campus. And you've heard that Dr. Carruth is the dean and professor in the College of Nursing and Health Sciences at Southeastern Louisiana University. And each will present on the barriers, challenges, and ethical considerations faced in their respective communities and offer their insight into how these might be resolved. Amber, you're up. Thank you.
All right, so thank you, Dr. Levine and Casanova, and thank you all for participating in this conference. This conference is different than previous emerging issues conferences that I've attended in the past. This is my first time in this role as a presenter, and I'm just welcome, and thank you for being here. So I have the privilege and opportunity to share with you guys, and getting to do so by a virtual presentation is probably a great thing because COVID has made me even more terrified of crowds. And today I'd like to share a few considerations with you. I'll address a few barriers and challenges that many of our rural and agricultural communities face, what our roles are as occupational health professionals, and why we have an ethical obligation to these rural and agricultural communities during this COVID-19 pandemic. And I'll start by sharing this brief story. Next slide. Thank you. So a few months ago, one of the senior leaders in our organization reached out to me about a potential COVID-19 exposure that occurred at a local family practice clinic. This local clinic was not affiliated with a hospital system or corporation, but rather a private practice. The local team had recently provided care for a symptomatic patient that fit criteria and underwent testing for COVID-19. At the time care was provided, the staff were not wearing personal protective equipment that was required for protection from this virus. They did not have PPE other than standard gloves and surgical masks. They found themselves concerned and ill-prepared for the exposures such as this that required enhanced droplet precaution PPE. Our leader, who provided years of experience and expertise in the field of occupational medicine, was contacted by a physician from this local clinic who shared the details with him regarding the exposure. Knowing it was only the beginning of this pandemic with an unforeseeable future, the provider knew he needed to allocate resources and provide proper protection for the clinic staff going forward. This potential exposure was an eye-opener for this clinic and the clinic staff, and it created a desire to ensure their safety going forward. With collaboration and coordinated efforts involving this senior leader at our institution, the local clinic's physician, and the leadership in Northeast Texas Public Health and the Regional Advisory Council, we were able to allocate N95 respirators, gowns, and face shields for this local clinic. I left my clinic early one day, drove to the local public health department and gathered the supplies, and then I delivered them to this local clinic. When I arrived at the clinic, I provided training and resources to the staff based on CDC's guidelines, recommendations, and I also provided training for proper donning and doffing techniques as it relates to PPE. I brought equipment and I qualitatively fit tested the staff with the N95 respirators that I received from the Public Health Department. I educated the staff on the importance of fit testing, how to properly don an N95 respirator, and how to get a proper fit every time you use it. I completed this just-in-time training for these health workers in the rural community. And because of this recent initial exposure to the staff at this clinic, I modeled this PPE for COVID-19 while also protecting myself. So to them going in, I may have looked a little extraordinary or just plumb crazy just because this is not something they're familiar with seeing. But to me, walking out, I felt that we were all a little safer. Next slide, please. So occupational health professionals are tasked daily with promoting health and wellness and preventing injuries. We protect our workplaces, help cultivate safe working environments. In normal day-to-day operations outside of a pandemic, the presence of occupational health professionals can easily be eclipsed by the essential priorities of our industries and healthcare systems. Though efforts to protect employees from harm and prevent injuries are important to everyone, they can easily go unnoticed. If an injury or exposure occurs, people remember. If we prevent it from happening, there's no event there to remember. And of course, we cannot prevent every exposure or injury from occurring, but we take efforts daily to recognize and to mitigate those risks. Together, industries and healthcare systems have goals of increasing productivity, reducing costs, and maximizing profits. The product of the industries vary. The main product of healthcare systems is to provide the highest quality of care for members of our communities. Occupational health professionals operate behind the scenes to protect and prepare our workforces from such events. But when an event such as a global pandemic occurs, occupational health teams are brought to the forefront to protect, train, educate, inform, and lead by example. Employees look to us for guidance on how to protect themselves while they provide care and services for others. Next. So there are several challenges that these local communities and healthcare providers face. And so as you are aware, many non-essential businesses were forced to close to decrease socialization and minimize these potential exposures. But many essential businesses remained open to continue providing service and care to members of our communities. Of these essential businesses, small provider and dental offices remained open to provide care for their patients. These healthcare providers face many challenges. Most are not equipped with occupational or employee health services to turn to for direction and guidance. In conjunction, they lack adequate personal protective equipment to properly protect their staff and are limited on obtaining resources at this time because of the global shortages on PPE. These providers need PPE as well as the knowledge regarding donning and doffing techniques to adequately and appropriately protect themselves while they perform these daily activities providing care for these members of our communities. Next slide. They're also challenged with trying to understand and apply the guidelines and recommendations because there are so conflicting forces circulating. This is overwhelmingly by the constant changes in response to newfound data that continues to surface in this incredibly fluid environment. I personally understand the confusion that comes with trying to interpret the new data and the updates and recommendations, and I work in this environment. I've made several notes throughout the progression, applied these guidelines to practice, and I still continue to try to understand, learn, and adapt to the ever-changing environment. So even though I work in this profession, I found myself in situations where I have to stop, think, and ensure that I'm providing the most current information because the world seems to be moving so fast around us. I can easily see how others who don't work in this profession can easily become overwhelmed with such information. Next slide. So our role as the healthcare provider, we as healthcare providers have several options in these situations. We can decide to step in and offer assistance, or we can stay the course and continue to fulfill the obligations of our job descriptions. If we step in, we must understand that the role of the occupational health professional in this situation is not to decide whether a practice can remain open or be forced to close. Ethically, there are the minimal obligations of an occupational health professional to provide support for these practices and businesses in our communities. What should we do if there's been an exposure to practice staff in a situation? We cannot send an essential provider home if they are the only one available to care for patients. Our role is to provide the most current guidelines and recommendations for safe practices, We have the ability to research and find resources that are available and acquire personal protective equipment and supplies for these rural clinics. We educate ourselves on these current guidelines to ensure best practice with our daily assignments, and we can share this information with our colleagues and local community healthcare providers to allow their practice to make that determination. So obviously supply resources will vary in communities based on the availability, but the information, training, and educational resources has the ability to be more consistent. There are several avenues by which communication is shared, and there are several sources of communication. There are several entities involved in providing information on best practice, but often the information can be conflicting among the several different sources. So to provide consistency and clarity of best practice, most occupational health professionals depend more on the guidance and resources available by the CDC. The CDC has much to offer as well regarding mitigating risk and safe practices to instill in the workplace and prevent exposures. Next slide. So there's quite a few examples I'm going to share with you about things that we've done. And our occupational health clinic and the Institute of Occupational Safety and Health, TIOSH, has worked tirelessly together during this time to continue providing care for our patients, our clients, and our employees. Our clinic specifically cares for employees of this institution as well as employees of our clients in the community. And prior to the beginning of this COVID-19 pandemic, the amount of time we typically spent with patients in our clinic was on average evenly split. So half of our patient encounters consisted of our own employees, and the other rough half were employees of our clients in the community. But as things began to progress through the pandemic, our client-patient encounters reduced, but employee encounters and obligations significantly increased. We have done so many things, and it's definitely something to be proud of. We've created algorithms, online questionnaires, and entire processes that continue to protecting our workforces. There with other members of our health, we initiated the screening processes that are still in place. We provided educational materials and trained staff from several different departments within our organization. We managed screening stations, supplies, and processes for these screening stations. And we're also responsible for making return to work decisions based on travel, illness, and occupational as well as non-occupational factors. So we've created these algorithms and online questionnaires to improve efficiency, and we are systematically updating these tools and processes with the changes and guidelines that occur in this fluid environment. Because of these efforts, all of our employees, patients, and visitors are carefully screened and have temperature checks prior to entering the facility. This is all an effort to protect our patients, visitors, and staff. We've received several calls from some of our clients as well as other local businesses and shared examples of our processes and efforts to protect their own employees. We've provided information to members of our communities to help prevent the spread, reduce potential COVID-19 exposures. The main source of information we provide comes from the CDC. We use the knowledge and expertise we've gained from the education and experience, coupled with best practices and resources from primary sources such as the CDC, OSHA, and NIOSH. And there are other great avenues of information, specifically for occupational health nurses, the American Association of Occupational Health Nurses, and for providers, Texas College of Occupational Environmental Medicine and American Association of Occupational Environmental Medicine have several resources for providing information, updates. They have question forums, FAQs, and so more. But these sources all help guide our efforts to protecting our workforce. Beginning of this pandemic, during monthly unit meetings I provide for our clinic faculty and staff, I mentioned some of these challenges that we were having, some in the community and some that we personally were facing. And one of those things we were facing was diminishing PPE. So our supplies were running low, manufacturers were depleted. It's hard to obtain items that aren't there. Our emergency management supply that we found of N95s were expired. So I updated everyone in the meeting about the current status and our efforts to reduce waste and preserve PPE, such as wearing them for extended periods of time, placing them in a paper bag, things of that nature. But after this unit meeting was over, a couple of our residents, our VP of Safety, Health, Environment, and Risk Management, and I discussed options for what we could do to help move forward. We talked about the possibility of fixing the N95s from the management supply, because we had previously investigated and learned that the mask's filter was still filtering within NIOSH specifications. The problem was that the elastic straps had lost their elasticity and did not pull tight enough to provide a proper facial seal. This discussion led to several what ifs and then a walk across campus to find resources in our materials management department, all while brainstorming and considering possible solutions to this problem. The result was monumental. Our residents, with the help of several employee volunteers working in the assembly line, were able to retrofit and put thousands of N95s back into supply and available for use. Several quality control measures were observed and quantitative fit testing was completed on each to ensure the safety of those who would don them in the future. We then took these retrofitted masks and quantitatively fit tested and trained our own staff on safe measures along with preservation of the PPE. Next slide. Our goals as occupational health providers are to prevent injuries and illnesses and protect our workforce. We find ourselves in our current roles because of a spirit of inquiry and a willingness to help others. A pandemic occurs and a virus spreads across countries and through our communities. It is our obligation to ensure that not only our immediate workforce is protected, but that the workforces in our communities are also trained and protected. A quote by Helen Keller, "Alone we can do so little, and together we can do so much." It speaks volumes to this consideration. The more people we have following the best guidelines and recommendations and properly protecting themselves, the more people we have to help us support, aid, and protect others in the community as this situation begins to progress. I appreciate what all of you do in effort to provide care for safe working environments for our workforce. Continue to collaborate with the members of your interdisciplinary teams and also find ways to share these efforts to help others in our communities. Thank you for your time.
Thank you so much, Amber, for that really informative presentation. Now we have Dr. Ann Carruth. Ann, right away, I'm going to mute myself now. Thank you.
All right, thank you. Good morning, and thank you so much for the opportunity to present. I'm going to be able to focus a little bit on telehealth and the impact of telehealth services in the rural community, and also share some of our journey that we've had as healthcare professional trainers at a rural university in Louisiana. So I'm delighted to be here. I appreciate the introduction by Dr. Levine and Vanessa, and I'll just get right to it. Next slide, please. There we go. One more. Let's see. There we go. All right, thanks. So I think everybody that's participating has been impacted by telehealth in one way or another. But just to kind of review the fact that telehealth has over three stages during this COVID-19 pandemic. And in March, when we were really identifying the need and the fact that this was going to become a pandemic, we started in the community settings asking people to try not spread the virus, asking outpatient care to be deferred. And in terms of telehealth, prior to COVID-19, high volume for telehealth might have been considered less than 100 patients a day, but now on average, high volume might be as many as 600 patient visits a day. So you can see from that alone, the transfer from face-to-face to telehealth visits for individuals in the community setting. So while the hospital surge increased, there were a lot of concerns about conserving PPE. There was a lot of discussion about how to best give the clinical services. And then there was a lot of discussion about using technology to continue to make sure that family members and friends were connected with each other. Interestingly, physicians and other medical personnel were reassigned and triaged. And I know in our own community hospital, a lot of our physicians were assigned to the one and only infectious disease doctor, and basically changed functions during the period of time to help that individual and to help with the surge of COVID-19 patients who had been admitted to the hospital. At the same time, there was a strict visitor restriction that was put into place, and this impacted our ability to train healthcare providers most significantly. We are considered visitors when we are hospital, whether that's for clinical and acute care setting, or whether it is part of the population-based experiences in the clinic setting. So, we have multiple contracts in place, and we were impacted there in early March. I would addressing 3 or 4 contracts and impact of contracts a day. It was we were in crisis just like everyone else was. So, and we hope that right now we're in the post-pandemic recovery phase. We do not know how long that will last. Emergency visits will resume since they were down. We know that a lot of people have deferred their care, their mammographies, etc., during that period of time. And so we're now seeing that individuals are starting to reschedule. And then, of course, we canceled elective surgeries, and those are now more prevalent. Next slide, please. So for a long time, telehealth was sort of in a limbo phase. The technology was there, but the implementation was not. As a result of COVID-19, there have been a lot of policy, legislative changes, waivers that has made it easier for telehealth to be implemented. And so that is what we've seen in a very short period of time. And probably the 2 most important things that have happened is that Medicare, Medicaid, CMS allowed telehealth to be expanded, allowed payments through telehealth, and then also the waivers of individuals within states and across state lines as far as their practice and scope of practice and their ability to practice. Next slide. So these are just some of the waivers, this isn't all of them, but these are very significant. Geographic area was that telehealth is primarily done in shortage areas and in rural health, and the waiver allowed for telehealth to be performed in rural and urban areas. We added the ability to conduct telehealth in a patient's home, and the licensing agencies looked at waiver and specific guidelines. So if you are wanting to know by state what those waivers are, the Federation of State Medical Boards can provide that information for you. Next slide. So in Louisiana, this is just an example of what was waived, and very significantly, the fact that telehealth has always required a HIPAA form. An example of that would be Zoom for Healthcare, which is a specific platform, and it runs about $200 a month for 20 individuals to use that. So you can see that that is much more expensive than an individual account of Zoom, which is $15 to $20 a month. And so by waiving that, the rule or the need for it to be HIPAA compliant, agencies were able to convert to Zoom or other ways of being able to provide those services. So we're able to even use telephone calls, FaceTime, any kind of video conferencing that they had on their computer, Skype, etc. And those could be used, even though they are not considered HIPAA compliant, they could be used to provide health services, and made it much, much easier for individuals to use telehealth. So next slide. This is just a great figure that was from the Journal of American Medical Informatics Association. I know it's hard to see, but basically it's just a depiction of the demand of care as a result of telehealth or the need for telehealth, and over time. So initially there was a huge increase in demand, and then a response, not only in the community setting, but also inside the facilities, the acute care facilities, where we're able to use the telehealth carts and peripherals to be able to provide visits and consultations when there was a shortage of physicians and other healthcare providers. And now we're stabilizing. And now, of course, we have the opportunity to, a little bit of an opportunity to start thinking about the ethical implications of telehealth. Do we continue that? Will it stay? Will it continue to be reimbursable? And most importantly, what are the outcomes? What are the patient outcomes? What are the health outcomes? Can it address health disparities? And so I think we will have a great opportunity for a lot of different research and discussion and policies that I hope will impact positively patient outcomes in the future. So next slide. So I get to tell you a lot about my college, which of course is lots of fun for me, because I'm the dean of what I consider the best, school of nursing in the whole wide world. And so we have roughly 3,400 majors across 13 programs. So we are not part of a medical school or a health science center. We are a university, but we do have a lot of healthcare related programs, and I will easily say all of them were impacted significantly. So unique to our program, all of our programs have they are required as part of their curriculum to have an internship, a practicum, or a component. Most are done either throughout the program or at the end in their last semester. Many of them have required numbers of hours associated with their programs as required, either by the boards within the state of Louisiana or their accrediting agency. So we do have 5 master's degrees, and we have 1 doctorate of nurse practice degree as well. Next slide. So I wanted to just kind of share a little bit about our journey across these 3 stages. Before the pandemic, we had very few undergraduate classes online, and we had very few faculty that taught classes online. So at some point, with strict visitor restrictions, once they were put into place, we started having agencies suspend our ability to do the clinical practicum or internships within those agencies. So at the same time, we had the university, every university in the country was quickly moving to remote and using video conferencing and other online technologies to teach. So we tried very hard. Once we had an inkling that was happening, our faculty kicked into high gear. We front-loaded clinical hours. I'm not a fan of 12-hour shifts, but faculty were willing to take students 12-hour shifts on the weekends and the evenings, and we encouraged that to occur so our students would get as much experience as possible. So at some point, we were told we could not bring students to campus, which meant that our alternative plan of simulation was not, we could not do that. It took me several weeks to really fully appreciate the fact that we would not be able to come to campus or be able to continue in that role. So right now we're in the post-pandemic recovery, and we are slowly being able to come back to campus. We run an accelerated program, and we are able to go to clinical at this point in time and return back to classes and clinical and skills labs. Next slide. There was a lot of ethical concerns in terms of training. We had to make a lot of decisions, and of course, when you're having to make them that quickly, you always know that you probably will not make all the best choices, and so that is, of course, problematic when it impacts so many people. We did have calls from parents and from faculty who were very concerned about the risk of exposure for their child or family member in the clinical setting. We had many discussions about the risk of PPE, the availability of PPE. Did we need to limit? Did we need to, come up with policies regarding specifically to COVID-19? etc. And at the same time, of course, faculty and students were trying to take care of their own families. They were trying to get their schoolwork. They had challenges with their connection. And, you know, they were grieving their own milestones because everything was canceled. So I do also just want to make a point about the restrictions on visitors. We are just now seeing the restrictions being lifted for family members to participate in the clinical settings with their family members. And so I hear every day stories about people who have been told they can't be with their loved ones during surgery, they can't be in the hospital, they can't be in the rehab. And I think this is going to have long-term impact on mental health. It's just an overwhelming burden, I think, on families with their loved ones during this critical time. So next slide. It's just an example of one of many Google Meet sessions that we did. Next slide. And, you know, students had to, you know, they were told period they would be going completely remote. A lot of our students had challenges with adequate technology. This is a student practicing with a faculty member prior to going remote, because really no one had ever used Google Meet. Very few people had used Google Meet before we had to move remote. So next slide. Faculty did not, by and large, our faculty do not know remote or online. You know, the majority of our faculty teach face-to-face. We do have online programs, so some of our faculty were fine. Mandatory faculty training day. This was the Friday before we went remote, the following Wednesday. Yes, we had over 50 people there, so I violated the governor's rule at that point in time, but I never dreamed that all of my faculty would actually show up. So, but we had a great day. Nobody became, and so it was very helpful. I was able to, you know, talk about expectations, and we had, you know, sessions that I think were very helpful for faculty. Next slide. We also created a pop-up help desk and partnered faculty that were experienced with faculty that were not. Next slide. We have a daily huddle, and I just really want to share that I know that we share this in common, that during this period of time, our communication increased, not decreased. Our phone, text, email, pretty much the burden of that significant over time, lots of webinars, and lots of Zoom and video conferencing. So next slide. We did get communication from our boards and accrediting agencies, and this was very significant. And I just want to point out that there was not one accredited. I think we have 9. We have 9 accredited programs, and all of them have some stipulation and discussion about the number of required clinical hours, practicum hours, and there was not one clinical accreditation organization that any of those hours. So some were very specific about what you could do in lieu of those hours, and some were not. But it was a very big challenge because we had started a semester, and then we had to figure out how to get the clinical hours for our students, or else we would have had to give them an incomplete or make them come back in the summer to finish their semester, or in many cases, the inability to graduate. So it was important that we try to address this. So next slide. So telehealth counseling, our counselors telehealth before. We very little experience with telehealth counseling at the time that we went remote, and agencies were not letting our counseling students continue in that setting. We had to change to telecounseling, and all students and all counselors were required to take 9 credit hours of how to counsel in a telehealth setting before they were able to go back to clinical. So of course, this was all very rapid, ongoing process that we were going through. So next slide. Speech pathology, they were probably the most nimble. They purchased Zoom. They converted all of their clinic visits to a Zoom visit. They did a lot of creative sessions with children for speech pathology sessions. So this is just a picture of one of, she's actually my GA. I would like to point out that one of the challenges that we've had is that the agencies, the accreditation agencies have also changed their supervisory requirements. So CSD, for example, has gone from that they could monitor 4 students in sessions with patients in an hour, and it's now one-on-one. If they do telehealth, it's one-on-one. So that's a significant change in the amount of time faculty are having to spend in supervision. Next slide. Our nurse practitioners students, thankfully, they're required to have 600 hours, and they were most all of the agencies that they were placed converted to telehealth at the same time. So they were able to gain experience with not only COVID screening, but also various clinic and specialty with using the telehealth. So next slide. We had to get very creative with our undergraduate nursing students. We were not allowed to come to campus for skills return. So this is just one of our nursing students who has used one of her favorite stuffed animals to demonstrate how to place eardrops in what should be a human being. But we were very proud of our students. They rose to the occasion, faculty rose to the occasion in being creative and being able to demonstrate what they needed to for the rest of the semester. So next slide. We have doctoral project presentations for graduation, and we converted. We usually come together. We usually have a big meal. We usually have a good party. All the family members come. It's like a dissertation defense, and we weren't able to have that. So we were able to do all of this using video conferencing, which was helpful. Next slide. I would like to make a comment about volunteerism. You know, we've lived through Hurricane Katrina in this part of the world. And after Katrina came and went, there was a huge influx of people and responsiveness in terms of, we anticipated that as well during this period of time, but I have not seen it. I signed up statewide as a volunteer. Our students did too, but we really just haven't been asked to have a lot of volunteer opportunities, which I just think is interesting. It may be that will come later. We were, though, for our PPE from Louisiana Department of Health, and we were also asked to volunteer the few hospital beds that we have in our simulation labs, which I did not respond to that email. I don't know if anybody else did, but I just couldn't even imagine giving my beds up. I would be bedless at this point. So anyway, luckily we did not need them in Louisiana, so that was really good. We have had a lot of volunteers sewing masks, and of course donating food, especially to the hospital area. And we've participated in trying to encourage our heroes at Change of Shift and at other times because of their dedicated help with our students and our programs. Next slide. We did donate our supplies. We were asked by multiple agencies to donate supplies. We donated to the one health system that's here locally and is in a rural area. We gathered across our various programs and donated. That has raised concerns at this point in time because clinical agencies are now asking us to bring our own PPE when we bring our students into the clinical facility. Luckily, we were able to source PPE for most of our programs. Our athletic training program is still looking for an appropriate place to purchase masks, and so we're trying to get that worked out between now and the beginning of the semester. So next slide. We did have a campaign, and of course we sewed masks for our alumni and our graduates. So we're in the process of getting those out now. So we've had a lot of fun with that. I bought a new sewing machine and relearned how to sew a straight line. So it's been fun. Next slide. I did send out, things is that I've been separated from faculty. I don't see them. We have not been here. And at some point around Easter, spring break, I sent a personal handwritten note to every single faculty and created a superhero educator pin and sent it to their home. And this is one of our faculty that just posted on social media how much she appreciated getting that. So I thought I'd share that. But you know, the challenge of staying connected is very significant during this period of time. Next slide. And I'll just end with this slide. We did get permission from administration to do our pinning ceremony drive-through. So I'm very proud to say that all of our seniors did graduate and graduated on time. Some of them chose to go and take an emergency disaster license and had gone to work probably a whole month in advance to participate in our drive-by pinning ceremony. And I don't know about social distancing, don't look too closely, but it was really nice. It was 86 students that participated in that. So I appreciate it very much, and I'm looking forward to questions.
Thank you, Anne, for that great presentation. I really like that, your pinning ceremony just now, the last slide. So we have time to take some questions and have some discussion. I would like to just start out by asking Amber a question. Amber, how prepared do you feel in the occupational health clinic and in your outreach to rural communities and practitioners in the event of a surge in this part of Texas? We're seeing an increase in positive COVID cases all over Texas. Do you feel more prepared now than you did in March, for example?
Definitely.
And what would the challenges be?
Yeah, so I definitely feel more prepared now than I did in March. I think yesterday looked back over some emails, correspondence back and forth, and I thought, wow, things have changed a lot just over the last 3 months. So, but many of the challenges that we face in trying to protect our own workforce and to share this information with our communities is just the lack of PPE. That I think that's probably the biggest, the lack of and the inability to buy it just because things are depleted everywhere. But we've received several donations from different places, and like I said, we worked with our teams here to put others N95s back into production.
Dr. Casanova, we're monitoring questions on this end. So if individuals want to submit questions, I do have one also, probably for both Amber and for Dr. Carruth. So I was struck by a statement I think Dr. Carruth made to the effect that healthcare and health education are contact sports. And so we've had to how to play the sport without having contact. And that seems to be accentuated in rural communities in particular. So let me just ask, given the innovative things that we've done or we've tried to do, is there a sense, and this is empiric at best, that the outcomes have been sacrificed in some way, that have not been able to adequately deliver care or to train individuals to deliver care?
Of course, that's an ongoing discussion and concern, and we won't know the impact, I think, for many months to come. All of our students in nursing they're in the process of taking their exam, their NCLEX exam, but they're delayed. Not all of the testing sites have opened. So that's going to impact, the ability to be licensed and to continue employment and to meet the needs of the shortage. The other thing we can make the case that using telehealth and being remote was successful in that we got through the semester. But the reason we got through this semester is because we started the semester face-to-face. We had some time with our students. We had some idea of our students' capabilities. We had our contracts in place. We had our relationships intact. We could not start, and I've told my provost this, we cannot start a semester remote with the intent to stay remote the entire semester. I don't think we can do it, and I don't think our accrediting agencies will allow it.
So what's the solution, Anne?
I'm hopeful that if we have a resurgence, that we won't be, that our activities won't be suspended. And I have had conversations with several chief nursing officers at this point and chief medical officers. And, you know, one of them said to me, this is like the best experience that these students could have had, and yet they've missed out on this experience. And so nobody had time to really step back and look at what would have been a creative opportunity. I would have been willing to send students in just even observing, but everybody was trying to make everything work so rapidly that I think that was the decision that they made at the time. But I'm hoping in a resurgence, we will be able to make recommendations, and they will make recommendations for creative ways for our students to at least stay in the setting so that they can continue to see the healthcare system work as it should.
Right.
So we do have time for a couple of questions that have come up actually in the chat box here. You can probably see that, Dr. Casanova, but if not, thanks to Dr. Carruth and Ms. Becker. The question is, have you come across any preliminary data on patients' medical compliance, appointment cancellations, no-shows with the move from in-office to telehealth visits during the pandemic?
And do you want to take that one, or do you want me to?
Yeah, Amber, you go first. Yeah.
So I don't have any data collected on what that looks like. I think the things are just happening so fast that it's, as we're trying to reel it in, we're also trying to start coming. But I will say that we have used telemed in our own clinic. Our patient volumes on the client side decreased. We picked up with our employee population, and a lot of that is because of those regulations being relaxed, standards not. They're just kind of being pushed out, so DOT exams aren't having to be done right then necessarily, just to really prevent exposures and minimize, just the risk of coming in contact with several people in a facility.
What we're seeing at the hospital here in the health system here is there was a fair amount of compliance with use of telehealth, but of course that was initiated a lot of times by the patient, so it was probably selective. Now that we have moved into phase 2 in Louisiana, though, I do know that at least what's reported by the hospital is that the demand for telehealth has started to decline. And so, they're going to have to decide whether or not they are going to continue that service. But I also think it's dependent upon the age and the comfort level of using technology as to whether people are going to continue to adopt this methodology.
I do think that it is a good resource, especially for our members in rural communities, just because it's harder for them to get out and socialize and to make that long drive if they are far away. So it makes it easier to meet those appointments and still be able to have care.
So I think we have time for one more question. We're doing well today. So this one is for Dr. Carruth. Maybe a kind of a tough one. Do you see or do you detect any differences as best you can tell in the Louisiana response versus the Texas response?
I haven't paid any attention to the Texas response. I'm so sorry. I've paid attention to the Louisiana response, and I know, I hear that there's an uptick in Texas, but I'm afraid there's going to be an uptick in Louisiana. So we are probably going to be right behind you. What we are seeing here is the college age students. Now that the restaurants have opened back up again, there's an uptake in that college age, as far as the number of cases. The hospital are recovering. They are at a low Ochsner system. I think they're all-time high across Louisiana and Mississippi with, I think, 800 patients. They're down to 75 at any given time. So they're definitely recovering and seeing a good response. I've been very impressed with our governor's response at the state level. He's kept us informed. I think he's made great decisions about our social distancing and the policies, with the exception of not letting family in with patients. That was a directive from the governor's office. That one was a really hard one to work with. So I don't know how that compares to Texas, but you probably could speak to that.
So yeah, we followed very similar processes with that. We initially did not allow visitors in, and then we started to get a little more lenient with that because we have patients admitted in the ICU and inpatient that are alone and they're terrified. And we also have outpatient clinic visit patients where the patient themselves has Alzheimer's or dementia, trouble communicating things and remembering medications, and trying to relay that information given to them from a provider during that visit by the time they either make it out the door or home to their giver or loved one. The information just isn't being communicated there. So initially when we looked at kind of opening things back up, in steps, not full force, not all at once, we started to let one visitor per patient on the inpatient only, so ICU and med-surg units. And they were carefully screened at the front, just like all the others were. But then we started with outpatient as well. And so far, we haven't had any major issues, complaints, or anything of the sort, but we did have quite a few complaints when the visitors weren't allowed in. So, and just another example to piggyback off of that was in our oncology department, we have several patients coming in for chemo and treatment of that nature. And they're here for several hours at a time. So it's hard for them to go through the things that they're going through and receiving treatment while they're sitting there alone. So they really need, somebody to be there and hold their hand. And it's nice that we are getting back phase of allowing visitors in, but also keeping safe, precautions, screening them, and only one per patient at this time, just to evaluate how things progress.
So thank you, Amber and Dr. Carruth. I'm going to turn it over to Dr. Casanova for the wrap up on this, but really do appreciate it.
Thank you both, Anne and Amber. I think you bring a really interesting perspective to the challenges and barriers that we're seeing in rural communities, both health professionals and providers in rural communities that are often overlooked. And of course, and the unique challenges faced by nursing students in this time. And thank you all to the participants for your questions and for your attention. Thanks so much.
Thanks again, Dr. Casanova. We're going to go ahead and move quickly. This is a part of our conference where we have to be on a very tight schedule in order to allow time for us to come into the grand rounds on time at noon today. So without further ado, I'm going to go ahead and just remind the residents presenting that unfortunately, not disrespectfully, I'm going to have to cut you off promptly at 10 minutes for your presentation. We're going to begin with Dr. Michael Wershing from Texas. who post-clinical year in emergency medicine in New York, and has spent 2 years here now at UT Health Science Center Tyler. Upon completion of our program here in just a few days, we'll be moving to an occupational medicine medical director role with Longview Regional Medical Center. So Dr. Wershing, you are on.
Thanks, Dr. Levine. So thank you for joining me today. I'm excited to discuss my project with you, improvement of current medical surveillance of Coumaphos exposure in Texas Animal Health Commission fever tick eradicators. Before I begin, I'd like to acknowledge the Southwest Ag Center for the funding of my project, as well as Dr. Nassim, my program director, and Dr. Rowlett for being my mentors throughout this program. Okay, next slide, please. So this is the introduction. The Texas Animal Health Commission plays a key role in limiting the cattle fever tick infestation through a tick eradication program that maintains a quarantine border along the Texas-Mexico border. Currently, Texas Animal Health Commission personnel use Coumaphos to spray and dip cattle for tick control. Coumaphos is a pesticide, which I'll discuss in detail later. And roughly, we have about 70 personnel that are followed in a medical monitoring program run by the UT physicians. Next slide, please. So just going to talk briefly about the background of my project. In the late 1800s, cattle drives from Texas to northern markets resulted in the disease bovine babesiosis, being called Texas cattle fever. There's three species of ticks that are known as fever ticks that transmit this disease to cattle. Luckily, there were control measures that had virtually eliminated these ticks in most of the states by 1943. But however, there's still a good amount of fever ticks which travel on cattle. And they really affect this hot zone here on the map that I'm showing on the bottom right, which is along the Texas-Mexico border. Next slide. So this is a brief summary of Coumaphos, which is a pesticide that the sprayers use on the cattle to get rid of the ticks. On the bottom left was a picture that we took at one of the site visits. And bottom right is one of the warning signs of a picture that I took in the Laredo vat. And this is on the top right is the molecular structure. If anyone has any questions about how Coumaphos toxicity or its mechanism to humans, please feel free to ask me at the end of the presentation. So next slide, please. So the next couple slides will discuss the UT Physician Medical Monitoring Program of the Texas Animal Health Commission personnel. So currently, these workers mix, spray, and handle Coumaphos on a daily basis, just like this gentleman above. In addition to this, they physically scratch or pick off ticks from the cows barehanded. And like I said, our UT group has been monitoring these personnel for 4 years with monthly blood draws for their cholinesterase activity. I took this picture at the Three Rivers vat. Okay, go ahead. So more on the medical monitoring basics. The objective of these blood draws is to flag any of these individuals whose cholinesterase levels fall below 75% of their baseline for either red blood cell or plasma cholinesterase. These individuals will then be removed from all pesticide handling exposure, and their blood levels are then rechecked at 2 weeks. The intent of this program is to prevent toxicity to the pesticide. So this picture shows the workers scratching the cattle, and the gentleman at the bottom is mixing and dumping more pesticide into a tank. Next slide. So the need for this program, Texas does not have a pesticide standard, unfortunately, so we monitored our program after the California pesticide standard. which has been used for USDA personnel working side by side with THC personnel. These workers' close contact and exposure to the pesticide provides a need to make sure they're safe. So here they are again. This tank on the right, you see some water and pesticide in there. The cows will essentially jump in and they'll be dipped and they'll exit at the end. And that's how they get their exposure to the pesticide. So next slide, please. So who are the workers most at risk? It's the workers who are near the spray boxes, which I'll demonstrate in a future slide. And of course, the workers who mix pesticide solutions daily. Next slide, please. So the aims of my project, the first one was to determine the risk factors for these depressed cholinesterase levels for both work-related and non-work-related tasks by the use of a survey that I created. The survey inquired about other personnel or medical causes of depressed levels, which I read in the literature. And the second aim was to conduct a work sites visit to 3 different locations in South Texas where the dip operations were underway to provide context for my survey. Next slide. So this is my hypothesis slide. Interestingly enough, some of the workers in the medical monitoring program have been removed from pesticide activities, yet they reported to us that they had little or no pesticide exposure. So that led us to the following hypothesis, that we believe that there may be factors other than work exposure to organophosphates that may have been causing consecutive depressed cholinesterase levels in these workers that were removed. So go ahead and move on, please. Next slide. So this was a demonstration. Go ahead and hit play. Let's see if it works. This is a spray box. Sorry if it's a little choppy, but essentially this box, you load the cattle one by one into it and close the door, and they get sprayed. This is water. This was just a demonstration, but normally that is the pesticide there. Okay, so next slide. So my methods, this was me handing out one of my surveys to the head supervisor of the THC program, Mr. Russell. Next slide. So my questionnaire consisted of 22 questions. It was reviewed by the IRB and the THC administrators before distribution. It consisted of questions about their work practices, the amount of exposures to organophosphates, their health history, and their compliance with PPE. Next slide, please. And this is a timeline of everything that went on dating back to August of 2019 up until when I presented to the MPH faculty in May. Next slide, please. So these are the results of my descriptive statistics. On the left, I have a pie chart. In blue, we had, the blue demonstrates the males. We had 46 males. The red portion are the females. We only had 7 females. On the right is a little table I created. The median age of the men was about 30 and a half. The females were 25. The oldest individual was a 65-year-old male, and the youngest was a 19-year-old male. Next slide. This is a stack bar chart. Okay, showing the percent of men and women that participated by decade. As you can see, the majority of them fell into the 19 to 29-year-old range. Next slide. This is a pie chart about the years worked at THC. In blue, as you can see, most of them worked less than 2 years at the THC. In gray, only 5 individuals had worked more than 5 years. Next slide, please. And this is another pie chart demonstrating the amount of exposure to organophosphate per week. In gray, 45% of the workers responded with greater than 3 exposures per week. Okay, so let's move on for the sake of time to the statistical analysis. Next slide. So I created a chi-square analysis of the exposure factors, and the ones that were statistically significant are shown here in orange. The variables here were gender, the amount of years worked, whether or not they are exposed, and if they dip OPs at work. So the ones in orange are the ones that were shown to have statistical significance. And those two were the years worked at THC and whether they dipped OPs at work. The others in black, unfortunately, did not show significance. Next slide. This is another table that I created. This deals with the medical factors, such as if they had surgery, if they take steroids, if they had an infection. The literature states that these can cause depressed cholinesterase levels. Unfortunately, I did not get any statistical significance with my survey and these responses here. So next slide. This is my limitations. The major limitation was that we did have a small sample size. We only had 65. We were anticipating getting 65 individuals. Only 54 actually showed up when we arrived. So we had insufficient power really to make conclusions regarding my hypothesis. Only 9 of the individuals surveyed had been flagged. So this small amount of positives makes any conclusion hard to infer. And there was some recall bias. Some of the workers had said that they had never been flagged, but in fact, we had documented that they had been flagged. So
Time to wrap up.
maybe some recall. And my last slide, my conclusions. So we suspected that there were factors outside of the work environment that could be causing consecutive depressed levels. There were only exposure-related factors, like I mentioned earlier. The study was limited by a small sample size. And like I mentioned, there were some workers who were not available on the days that we were there to survey them to participate. So that is it. The following slide should be my my references, and that's it.
Very
Thank you
good.
very much.
Thank you so much. We're going to hold till the end as they come in. If you make sure that you indicate the resident that your question is for, that will be helpful at the end as we wrap up. So next, Dr. Aga Kasiri, who came to Houston from family medicine training at UT Health Science Center in San Antonio, and is completing her MPH in occupational medicine training at UT Health Science Center, Houston School of Public Health. So Dr. Kasiri, I'm going to turn it over. Kasiri, I'm going to turn it over to you.
Hello, everyone. It's a pleasure to be here with you today, and thank you for your time. Today, I'm going to be discussing with you universal access to occupational health with a focus on community health. You see, back in 2007, the 16th World Health Assembly endorsed by the World Health Organization Global Plan of Action for Workers' Health, identifying concerns about gaps between and within countries for the exposure of workers and local health communities to occupational hazards and their access to occupational health services. Workers are the major contributors to economic and social development. Their health is determined not only by workplace hazards, but also by social and individual factors, which is what we're going to mainly focus in by today. WHO reports that currently only 15% of workers worldwide have access to specialized occupational health services that includes prevention of occupational risks, health surveillances, training, safe working methods, and safeguards for occupational health and safety. Occupational health activities are integral to the advancement of community health and improving the health of workers, industries, and communities, and which can be achieved through the well-coordinated public-private partnership with government leadership and substantial participation by workers and employees. Most corporations understand that there's a value in recognizing, measuring, and coordinating practices that positively impact the community. The presence in communities is accompanied by a social responsibility to bring safe and reliable energy for the development, to raise standards for overall health and healthcare services, and to create employment opportunities. You see, these actions are positive impacts, and they're referred to as health corporate responsibility. Health corporate responsibility has 3 major pillars, which is what we're going to focus on: workforce health, health social investment, and health citizenship. Next slide, please. Thank you. Workforce health focuses on ensuring health, safety, and productivity of workforce and work environment by establishing standards of health practices and care. It focuses on access to services and specialty health care related to business operations, specifically potential workplace risks and exposures. For example, safety in operational locations is one example of health and environmental safety. In this context, you can ask several questions that must be answered. Who is conducting what program and activities result in measurable impacts? Are there any external data that verifies these impacts, and what are the costs to be achieved? What other communities-based partners resources exist on this road safety issues? Next slide, please. The second pillar of we're going to focus on is health social investment. This is really a volunteer program in the community that helps form partnerships with local governments that are mutual benefit. Social investments are voluntary contributions by corporations to communities to create benefits, build relationships that support the businesses and their community. For example, social investment may include economic development, health programs, education, and environmental projects, sponsorships, and donations. To enhance the understanding of social, political, and reputational risks is really to get the stakeholders engaged. The areas of focus for stakeholders are to manage social, political, and reputational risks for the company. Furthermore, safeguard assurance is declaring to protect and uphold guarantee to verify effective relationships, plans, and incentives, competencies, and quality execution. Taking a closer look, we'll be discussing some of the examples of corporate health social responsibility. The scope of the priorities of health social investment is influenced by environmental health, social health impact assessment, referred to as ISHA. The purpose of ISHA is to identify and manage the potential effects of a project or policy on the physical, biological, socioeconomic environment and human health. There's an environmental impact assessment, which really focuses on the project, on the physical and biological environment. There's a social impact assessment that focuses on the people, the culture, and the tradition. And finally, there's a health impact assessment that focuses on the potential community health impacts related to the projects. All together, these are a form that you can synergistically find the benefits of finding an informed risk assessment, corresponding follow-on actions to mitigate the impacts. Next slide, please. So companies also benefit from the third pillar, which is the health citizenship. Here, the highlights the time and money where corporations contribute to work health issues from industrial nation and a global importance by participating in health organizations and engaging the private sector and leadership, summoning these organizations. For example, of the leadership participations promoting health citizenship includes convening the Institute of Health Metrics and Evaluations for Database Planning, or the Global Business Coalition for Health for Major Disease Threats, or the United States Chamber of Commerce Global Initiative. Next slide, and there's more examples available for you. Next slide, please. Here we have two examples of the community health social investment initiatives and examples that was carried out by Chevron. To the right, you're going to see an example of the Angola sickle cell initiative, which is an example of the social investment by Chevron. Here you have the public and private partnership between Angola Ministry and the Health and Chevron and Baylor International Pediatric AIDS, which was launched back in 2011. These three organizations came together to essentially focus on the reducing the morbidity and mortality of children with sickle cell disease through screening, preventative care, and symptomatic treatment of patients. The additional goals of the project was to include local and health professionals to diagnose and treat sickle cell disease. In 2011, over 353,000 newborns were screened, of which 63,000 newborns had sickle cell trait, and 8,351 newborn sickle cells were treated. So furthermore, they went out into maternities, and they also took their screening measures into the different areas. They also trained the healthcare providers, doctors, nurses, midwives, medical and nursing students, and they involved the community members. To the left, you can see the initiative in Colombia that involved 6 different entities: the Texas Children's Hospital, Baylor, Eco Petroleum, and Colombia government, to name a few. You see, these partnerships significantly improve the lives of the community through a program known as the Indigenous Health and Self-Sufficiency in La Guajira, aka also known as SAIL, which began back in 2014. This program was in 4 different phases, and right now we're in the 4th phase of this program. And the primary objective of the SAIL program was to support the reduction of maternal and infant morbidity and mortality rates in these indigenous areas, to expand medical access services, build capacity, and prevent illness by disease identification and surveillance, and partnering with stakeholders. The SAIL program furthermore focused on how to reduce the burden of malnutrition, which is the major cause of the morbidity and mortality among these indigenous populations. Some of the outcomes from 2014 to 2018 was delivering food packages, over 7,000 of them, and treating malnutrition infants. And to date, back in 2018, 0 malnutrition deaths were registered in Manura in 2018.
2 minutes remaining.
And thank you. So, improving the health of workers can be achieved through well-coordinated efforts by workers and employees, communities, and local and national governments. And the environment one works in substantially affects the health and human performances and lifestyle behaviors. Many established companies have recognized the value of improved health standards in the workplace and can go, next slide, please. Next slide. Thank you. So I have recognized the value of improved health standards at the workplace, and a holistic approach to health and safety may include programs that decrease and the stigma for self-reporting and physical emotional well-being concerns, critical in advancing universal access to occupational health and community health by ensuring a healthy workforce has strong linkage to strengthening the health of families and communities where we live and work. So by getting involved in the community through social health investments. Thank you. That concludes my presentation for you. And acknowledgement to Dr. Stephen Prangos and Nadine Anwar, who helped publish this paper. It was their project at Chevron. So thank you, and acknowledgements goes to them. We're open for any questions. Thank you.
Thank you so much. Again, if you have questions, just be sure to indicate who your question is for. We'll hold those till the end. So rotating back to the program, next is Dr. Ashik Zaman. Dr. Zaman also earned a Master's of Health Administration from the University of Oklahoma before coming to Tyler, where he has also served as chief resident and has worked, I would point out, has worked collaboratively with me on Milestones 2.0 with the ACGME. That's been great to have him do that and to work with him on that. So with that, I'm going to turn the mic over to him for his presentation.
Thank you, Dr. Levine. So again, my name is Ashik Zaman. You can see my team here, but really would want to mention that we had more than 50 worker volunteers help with this project. Our project is called the Development and Implementation of a Production Line to Retrofit N95 Respirators for Emergency Use. Next slide, please. A little bit of background. Beginning in March 2020, in the setting of the global pandemic, East Texas healthcare workers and first responders faced a critical shortage of respiratory personal protective equipment, which they needed to safely do their jobs. The UT Health Science Center at Tyler, as well as the Northeast Public Health District, known as Net Health, were home to a combined stockpile of more than 80,000 duckbill and 95 respirators. Most of these products were made between 2006 and 2010, and so they were all beyond their manufacturer recommended shelf life, though the term's expiration date were not indicated on any of the product or packaging. Next slide, please. So apologies for the little bit of the choppy video here, but you might be asking, why did we need to undertake this project if we already had a stockpile of 80,000 respirators? So in this case, a picture is worth 1,000 words. As you can see in the clip, the existing blue elastic straps in these respirators was dry, rotted, and fragile. Again, some of these were almost 15 years old, and thus, unfortunately, the stockpile that was available to us was unusable at the time. Next slide, please. So the bottom line is that in March 2020, there was a critical supply-demand mismatch. This project aimed to address that mismatch by refurbishing defective elastic material in that existing stockpile. One really big component of our decision to undertake this project was an FDA emergency use authorization in late February 2020, which allowed for the use of fitted face piece respirators beyond their manufacturer recommended shelf life. Next slide, please. So one important question is the filtering capacity of respirators affected by the shelf life? And the short answer to that question is generally no, the filter capacity is not affected. This is a screenshot from a group of NIOSH studies called CASE, and it essentially formed the backbone for the FDA's decision to issue its emergency use authorization, as NIOSH had previously demonstrated adequate filtration efficiency of large stockpiles of respirators. This included multiple stockpiles of the same make and model that our group worked with. Next slide. So in terms of methods, it's actually relatively simple. So we take something like the picture on the left and we convert it to something on the right. Next slide. But it's unfortunately, it wasn't quite that simple in prototyping. So we started with the model that you see on the far left and progressed through PDSA cycling and testing and doing quantitative fit testing really to make sure that our products were the best they could possibly be. And the version on the right side is the one that we ultimately ended up mass producing. Next slide, please. A major distinguishing feature of this study was the utilization of quantitative fit testing at every level of prototyping and production. Each prototype was rigorously fit tested prior to production and being scaled. Additionally, samples from each batch of respirators that we produced underwent fit testing as a key quality assurance step. Next slide, please. So I'm going to walk you through the steps that our production line took in retrofitting these respirators. So in step one, 2 holes were very precisely punched in the respirator. Special care was taken and quality checks were performed with respect to maintaining the seal integrity. We wanted to make sure that the holes that were placed did not actually compromise that seal. And so that was a huge part of our quality check process. Next slide, please. So step 2 involved the assembly of the rubber band zip tie units. You can see this on the photo on the right-hand side. There were a lot of different ways that people did this, but the version on the left we referred to as the butterfly technique, and it was probably the prettiest one. Next slide, please. So the next step was to combine these 2 pieces together to form a retrofitted respirator just by connecting the zip ties to those holes that were placed in the respirator. Next slide, please. So finally, we get to quality control and packaging. So we considered quality control to be one of the very most important steps. Among other things, we looked for hole placement. We looked for integrity of the rubber band, as these were sourced from a third party. We also wanted to make sure that the rubber bands were free from excessive twisting. And finally, once we got all these things in order, we performed flush cutting of the zip ties using a special tool. And finally, once the respirators were produced, they were put 10 per Ziploc bag and then 10 bags per box. So our essentially unit of distribution was 100 respirators. Next slide, please. So this is a graph moving on to results of our production run. So our first date of production, again, was the 20th of March, and we went until about the 15th of May. That accounts for a total number of production days of 39. We produced almost 80,000, so almost the entire stock that we had, 79,340 units, and that imputes an average units per day of more than 2,000. Next slide, please. So this next chart is a different way of representing that information. So this was fundamentally a quality improvement project, and one of the tools in QI is called a run chart. So the run chart essentially allowed us to look at the number of units produced per person per day and graph this over time. Next slide, please. So we previously discussed the NIOSH studies on filtration efficiency of existing stockpiles similar to the one that we retrofitted. However, we felt that it was important to study the filtration efficiency of our stockpile specifically. Working with an outside specialty laboratory, we sent 3 samples from each of 3 production years from our stockpile for filtration efficiency testing. This utilized the same efficiency testing protocol that NIOSH uses. As you can see on this table, the average filtration efficiency of all of our samples tested was 97.7%. And that means that all samples actually achieved better than a 95% efficiency standard. Next slide, please. So let's quickly discuss the impact of this project. Starting on the picture on the left-hand side, this was actually our very first production run. We made 80 respirators in 1 half day on March 20th. And these respirators were actually delivered the same day to the Tyler Police Department. And those police officers were able to more safely perform their duties given the work that was done. The 2 pictures on the right-hand side are deliveries that were taken to the Northeast Texas Public Health District, or Net Health. The distribution network of Net Health was actually a lot broader and allowed us to reach people who really needed these supplies the most. Many of these respirators went to rural clinics and to rural providers. One really kind of heartwarming story that we heard is that there was a clinic that was able to be open one day, but not the previous day. And they were able to do that because of the supply that they received from this project. Next slide, please. So this is a picture of the St. Paul Children's Dental Clinic here in Tyler, Texas. We had a great opportunity not only to provide their clinic staff with our respirators, but also to maximize their safety at work by doing quantitative fit testing, a worksite walkthrough, and continuing to collaborate with them. So similarly, St. Paul's Clinic was able to open its doors on the basis of the result of this project. Next slide, please. So finally, in terms of generalizability, we later found out in April that the state of Virginia was home to about 800,000 of the same make and model of respirators that we were working with. We were contacted by the Virginia Hospital Association and worked very closely with them to share our process and production line design. And just had an update a couple of days ago from the individual from the Hospital Association that nearly all of the 800,000 respirators that they had in stockpile were sent to more than 300 hospitals in the state of Virginia where retrofitting operations were conducted. Next slide. So that ends my presentation. These are my references, and I look forward to any questions.
Thank you so much, Dr. Zaman. Appreciate you being within the time parameter. So that'll take us in rotation quickly back to the Houston program with Dr. Paul Carey being next. Dr. Carey has his MD degree from the Autonomous University of Guadalajara in Mexico and New York Medical College. He interned in pathology and then has since come to Houston to complete his occupational medicine residency. He has a background interest in materials engineering research. So Dr. Carey, you are next.
Good morning, everybody. I hope you can hear me.
Yes.
Okay. Very well. So if we could advance the slide. So I'm here to talk to you about the regulatory and health effects of per and polyfluoroalkyl substances. It sounds very intimidating. I'm going to not make this as non-technical as possible. So if we could advance the slide. So we hear a lot about PFAS as the general nomenclature for this type of these types of compounds, and essentially what they are classes of molecules that have a long carbon chain. The hydrogens have been replaced by fluorine, and if they're completely substituted, it is a perfluoro. If it's partially substituted, they're polys. And what do these carbon fluoride bonds provide these types of compounds? It makes them very stable. It makes them resist things like heat, stains, water, oil, and grease. Because of that, they've found their way into a lot of specialized nonstick industrial and commercial applications. I'm sure people can remember things like Scotchgard, the carpet treatment, firefighting foams, electronics, paints, you name it. These compounds actually found their way into a lot of different commercial applications. Because of their stability, unfortunately, they persist in the environment. It's a big problem with PFAS. They tend to bioaccumulate as well, just because they're so ubiquitous within the environment themselves. NHANES study was a really important study that was done back in 2015, where almost 98% of the population, it was a cross-sectional study that was done to be able to look at these compounds, and 98% of the individuals that were involved in that study had detectable levels of PFAS within their blood. So there are about 5,000 different of these compounds today. PFOA and PFOS really represent the legacy compounds. Those are like the first generation of the PFAS. Essentially, they were their manufacture was stopped back in 2005 just because of the issues related to the environmental persistence and bioaccumulation in humans. So if we can go to the next slide. So there was an important study that was done by Hugh et al. In 2016, essentially that looked at data that was generated by the unregulated contaminant monitoring rule. And essentially what that did was it looked at 6 different PFAS compounds that were not regulated under the Safe Drinking Water Act. And that data essentially was analyzed in this study. And what they found was the number of PFAS-related industrial sites, military fire training areas, and wastewater treatment plants were significant predictors of detection frequencies and concentration of PFAS in public water supplies. They also concluded the number of military sites within their study area was associated with a 20% increase in polyfluorohexane sulfonate, 10% increase in both perfluoroheptanoic acid and perfluorooctanoic acid, and also a 35% increase in perfluorooctane sulfonate. They additionally concluded that the number of civilian airports with aqueous film-forming foams, personnel trained in using those, was significantly associated with PFAS concentrations above the minimal reporting level. So the next slide, please. And in 2019, the Department of Defense actually released their results where they looked at a number of different military installations across the United States. And they essentially found over 100 of these bases actually surpassed the EPA's health advisory in terms of PFOS and PFOA. So Within the state of Texas, those little, it's kind of difficult to see, but those little purple dots really, they represent military installations in which they have detectable PFAS levels. And what I did was I just selected 4 of those installations. Reese Air Force Base in Lubbock, they had a combined PFOS, PFOA level of 7,280. Ellington with a combined of 61,000 parts per trillion. Randolph and San Antonio, 182,000 parts per trillion. And the joint base in San Antonio at 680,000 parts per trillion. That's almost 100,000 times the health advisory level that's, that was given by the EPA. So we'll go on to the next slide. So what's the common factor here? The common factor within those military installations are the use of this aqueous film forming foam. And essentially they're complex proprietary mixtures. They're often used in Class B type foams. PFAS, they comprise a small percentage of the overall formulation, but they still represent grams per liter levels. They have historic use in military and civilian airports. Industrial use as well. We have pictures of the ITC fire here in Houston, in which a large amount of that film forming foam was used. There were concerns about ground and drinking water contamination. The PFAS are known to be very highly mobile. So, you could have a point source and, the potential for it to migrate is very great. And also, the effects of occupational exposure is something that is unknown. There haven't been a lot of studies in terms of looking at PFAS and, really getting an idea of what the long-term chronic effects of exposure are. So let's go to the next slide. So a study that was published by Dobraka and et al. in 2015, they essentially saw perfluorodecanoic acid 3 times higher in firefighters than adult males that were studied in the NHANES project. They concluded that firefighters may have unidentified sources of occupational exposures to PFAS. And Trowbridge et al. In 2020, this was a new study that was released looking at women firefighters, that they had a higher mean concentration of PFAS compared to office workers. And the firefighter position predicted exposure as well. So firefighters and officers had higher PFAS levels compared to drivers. And their conclusion also was that women firefighters were exposed to higher levels of some PFAS compared to office workers, suggesting a possible relation to occupational exposure. So we'll go to the next slide. Next slide, please. Thank you. So I'm not going to get into, the technical aspects of health effects and what the molecular basis is, but there's a lot of different theories about, how PFAS could incorporate itself into the lipid membrane of cells, affecting cell-cell signals. And but PFOA has been studied. And there is a role in its ability to partially act as a partial antagonist for thank you, for PPAR alpha. Next slide, please. So the health effects, it's postulated as PFAS, a endocrine disruptor. The jury's still out on that. In human studies, it epidemiologically, it's been showed to cause thyroid, liver effects, increase in cholesterol and uric acid, immune effects, which was summarized by the National Toxicology Program's monograph from 2016, ability to cause kidney and testicular cancers and preeclampsia. In animal studies, there are developmental effects, liver changes, thyroid, neurotoxicity, reproductive effects, and liver, testicular, and pancreatic cancer. The IRC, based on those studies, have classified PFOA as a group 2 possible human carcinogen, and the most recent generation of PFAS are limited. There's really no toxicological data available. Next slide, please. So the regulatory history, there's no federal maximum contamination level that's been promulgated in drinking water. There's no designation as hazardous under CERCLA, which is the Superfund, which governs the Superfund. The EPA in 2016 established a PFAS health advisory of 70 nanograms for PFOA and PFAS individually or combined. And the ATSDR, which is the Agency for Toxic Substances and Disease Registry, they did put out a provisional minimal risk level for drinking water, but that also, it's provisional, it hasn't been promulgated. Next slide, please.
Time to wrap up.
Okay, so the EPA published an action plan in February 2019 to develop regulatory maximum concentration levels. Nothing really has been promulgated in that area, or groundwater cleanup recommendations. They did want to expand monitoring and PFAS research efforts. Just recently, in March of this year, they were successful in getting PFAS into the 4th drinking water contaminate candidate list, which they will it looks like they're actually starting to get the ball rolling in terms of looking at these classes of compounds in monitoring under the Safe Drinking Water Act. Next slide. So in Texas essentially follows the EPA's federal health advisory at 70 nanograms per liter. They defer to that federal directive. And just recently in 2019, they also promulgated groundwater cleanup standards for surface and groundwater. I'm not going to go through that entire list, but in an effort to really safeguard drinking water supplies, this is a recent update in terms of the state effort. There are 7 states right now that have developed their own drinking water guidelines for PFOA and PFOS, ranging from 13 nanograms per liter to 1,000. Again, it's a hodgepodge of state efforts. There's no unified federal effort to really, tighten things up. So essentially, states are really promulgating their own regulation. Again, the EPA Federal Health Advisory for PFAS is non-regulatory and it's non-enforceable.
Thanks so much, Dr. Carey. We're going to go ahead and need to move on.
Very well, thank you.
You bet. Next, we're going to move to our last resident presenter, Dr. Marietta Shapiro, who also has a Master's in Business Administration and MPH, and has been a member of the Residency Advisory Committee, and is looking to wrap up her 2-year stint at UT Health Science Center, Houston School of Public. Dr. Shapiro, the floor is yours.
Hope all is well. Today I will be sharing with you some information about an occupational medicine case surrounding the heat-related fatality of a postal worker. I will be presenting on heat stroke with a focus on postmortem findings.
Next slide, please.
With some basic definitions. Heat-related illness denotes a spectrum of symptoms and conditions which can occur when there is a significant rise in core body temperature due to the body's usual cooling mechanisms, such as sweating, failing to adequately respond to heat exposure. If core temperature deviates significantly from its normal core temperature, around 98.6 degrees Fahrenheit, body organs and systems can't function properly, and consequently, severe and fatal outcomes can ensue. We'll touch upon the most serious forms of heat-related illness, heat exhaustion and heat stroke. Heat exhaustion results from the body losing water or salt in the setting of heat exposure. Signs and symptoms include fast heartbeat, sweating profusely, nausea or vomiting, fatigue, cold, pale, clammy skin, muscle cramps, lightheadedness, and headache. If heat exhaustion is not promptly recognized and treated, it can progress to heat stroke. This is a life-threatening condition. It's characterized by a very high core body temperature, greater than 103 degrees Fahrenheit, along with central nervous system impairment. In addition to the symptoms listed for heat exhaustion, heat stroke may present with the following warning signs: hot, red, dry skin, lack of sweating, confusion, convulsions, and loss of consciousness.
All right, next, please. Next, please.
At OSHA, I worked on a tragic but interesting enforcement case involving the heat-related death of a 63-year-old female mail carrier. She had faithfully served the United States Postal Service for 30 years. She had a past medical blood pressure, right in return to work July 28th. With an hour high temperature, USP truck absence is otherwise high conditions. Around 1:40 p.m. that afternoon, while on the route, she reported to her supervisor that she was experiencing difficulty due to her ankle pain and the heat. Though she was in distress, she was in distress and seek medical care. Around 3 p.m., a postal worker who happened to be passing by found the employee slumped over the steering wheel of her delivery truck, unresponsive. About 30 minutes later, first responders pronounced her dead after unsuccessful resuscitation attempts. The forensic pathologist who examined the deceased put down hyperthermia as the immediate cause of death in the autopsy report.
Next, please.
Initial investigation, the OSHA area office concluded the worker's death was heat-related and that the employer did not provide proper actions to protect the worker from this recognized hazard. Thus, OSHA issued a general duty clause violation. In response, the USPS began legal proceedings to contest this. In April 2019, the Office of Occupational Medicine and Nursing was consulted for subject matter expertise. My involvement in the case focused on conducting a literature review on the gross anatomy findings in the autopsies of heat stroke victims and developing counterpoints to the opposing parties' arguments. My work was to be used for preparation of written rebuttals and oral testimonies for this case, and to provide information to the department applicable to other cases. The OM expert witness for the USPS submitted a report upon which in-person testimony would be based. She asserted that for this death to have been due to a heat-related illness, certain characteristic features would have had to have been present. She argued that in the absence of such findings, the death could not be classified as a heat-related fatality. This expert claimed to have conducted an extensive lit review, yet she failed to provide any references for her statements, which questioned the validity of her report.
Next, please.
T97 position paper, the National Association of Medical Examiners define heat-related fatality as a death in which exposure to high ambient temperature either caused the death or significantly contributed to it. In its diagnostic recommendations, the association advises a patient history of exposure to a high ambient temperature and reasonable rule-outs of other possible causes of hyperthermia. Having a documented antemortem core body temperature is not absolutely mandatory to make the diagnosis if other compelling evidence is present. Circumstances surrounding the patient's death should be thoroughly considered when making a determination in presumed heat-related fatality cases.
Next slide, kindly.
Investigating postmortem findings in heat-related illness are reviewed an eclectic mix of peer-reviewed publications, including comprehensive review articles, experimental studies, and case reports. I created detailed deliverables and a concise summary table on the findings. My main takeaways are: autopsy findings in heat-related fatalities are relatively vague and nonspecific, which is largely consistent with the position of the National Association of Medical Examiners. Diffuse petechial hemorrhaging and pulmonary and cerebral edema are the most commonly noted postmortem findings, which may present on autopsy. Some authors have noted infrequently other findings, such as coagulation, necrosis of the heart, fatty change of the liver, small vessel thrombi, acute tubular necrosis, and those with longer survival from 12 hours to days from the onset of hyperthermia until death. Autopsy findings may be similar for those assumed to have died from heat stroke compared to those who died of non-heat related causes. Per a retrospective study by Adato et al., autopsy findings in presumed heat-related deaths can mimic similar pathological findings as sepsis, electrolyte disturbance, suffocation, electrocution. Consequently, classifying a death as a heat-related fatality depends greatly upon the involved circumstances. The absence of certain findings on autopsy does not preclude a determination of death due to heat stroke in the picture of supporting circumstantial evidence. To counter the argument of the opposing party, the USPS, that the worker could not have died from heat stroke since certain characteristic stigmata were not there, the most apparent consensus in the scientific community is that there are no absolute hallmark findings on autopsy for heat-related fatalities. Considering that the pathological findings may differ according to both the patient's survival times and the degree of bodily decomposition, the absence of certain pathology findings for the deceased postal worker does not mean that the death was not due to heat-related causes. Autopsies alone cannot be used to definitively make the diagnosis of heat-related fatality, but they can be valuable in excluding other causes of death.
Next slide, please.
Recommendations on engineering controls, administrative controls, training, acclimatizing workers, hydration, and rest breaks for industries in which workers are exposed to high heat. On the left is the recommended heat stress exposure limits for workers not acclimatized to working in hot environments. And on the right is for acclimatized workers.
2-minute warning.
Next, please.
OSHA does not have a federal occupational heat stress standard. OSHA relies upon the General Duty Clause, which requires employers to provide workers with a working environment free of recognized hazards, including heat exposure, which have caused or could likely cause serious injury or death. Federal OSHA has published on the website several relevant letters of interpretation, which may help guide employers. Some states, including California, Minnesota, and Washington State, have instituted their own standards for workers exposed to high heat environments. Hopefully, with governmental policies, increasing public awareness about heat-related illness, and concerted efforts by industry leaders to better protect workers from this recognized hazard, we will see major decreases in preventable heat-related tragedies. Occupational physicians are in a privileged position to help teach, inform, guide, empower, and advocate for healthier and safer working conditions. Tragic cases, such as the one discussed here, are calls to action, and they must inspire us to do more to protect workers.
You could skip 2 ahead, please. Those are my references. And just finally,
Recognize our hardworking postal workers who ensure our mail gets delivered 6 days a week, 52 weeks a year. Thank you for your time and attention.
Thank you very much. I'd like to thank the residents from both programs for their excellent presentations today, representing the culmination of their project work. While the QR code is presented here, we have time probably for about 2 15-second questions, and then we'll have to move on. But we do have 2 questions. One, very quickly, is for Dr. Wershing. Is there a similar risk for workers handling sheep and goats?
Hi. Well, I would imagine so. That's a question. I'm not sure if the tick also infects the sheep and goat, but I would imagine it does. So if there are workers who spray the organophosphate on these livestock, I would imagine that they're at a similar risk. Thanks for the question.
Thank you. Very good. And then one last question. I think this is probably for Dr. Zaman. There was a slide missed by the viewer that just says, briefly restate protection factors on your chosen model prototypes.
Sure. So I think there are probably 2 ways to interpret this question. Number one, from a fit testing standpoint, before any prototypes were taken to production, they had to pass a fit test, actually multiple fit tests. And then along the production line process, we would also fit test and pass a sample from every batch that was produced each day. And then in terms of protection factor, the other way to interpret it, I think, would be filtration efficiency. And that was something that we undertook kind of after the fact, but the slide I showed that the average filtration efficiency was 97% for all of the samples.
Great. Well, thank you for those responses, and thanks everyone again. So at this point, we've reached the part in our program where we're going to take our next break, very short at this point. We will promptly start at about 11:59 or 12 noon with our Grand Rounds speaker, Dr. Frank. So please go ahead and do your evaluations at this point, and we'll see you in just a few moments. So as we prepare to introduce our distinguished Grand Round speaker today, I just want to make a couple of very quick announcements. As you could see from the slide, any conflicts have been expressed by the speaker here. Also, at the end of today's conference, you should know that we'll be sending out a email to all the registrants with the QR codes and link for evaluation in the event you were not successful at completing the evaluation for continuing education purposes. Additionally, there will be a subsequent email when the video of today's conference is finalized with a link to that video for any registrants who were not able to attend but who want to view the video nonetheless. So with that, it gives me enormous pleasure to introduce our Grand Round speaker, Dr. Arthur Frank. Dr. Frank has a bachelor's in anthropology from the State University of New York at Buffalo, a PhD in biomedical sciences. His MD degree from Mount Sinai Medical Center. He is trained in both internal medicine and occupational medicine and board certified in both fields. As a commissioned officer in the Public Health Service, he conducted research at the NCI. His major research activities have included the study of occupational lung diseases, such as silicosis, occupational cancers, particularly those related to asbestos exposure, and he has worked in the area of agricultural safety and health. He is also a member of the prestigious Collegium Ramazzini, and from my own personal perspective, he is a teacher's teacher, a mentor, colleague, and friend, and I am so delighted to have him here today giving Grand Rounds. Dr. Frank, take it away.
Thank you very much, Dr. Levine. Your words are overwhelmingly kind, and it was my great honor to work with you, to have you as a colleague, both in Kentucky, where you trained, and where we worked together in Tyler. I have been gone from Tyler for almost 2 decades, but still have ties there. It was a period of time that was very productive in terms of work, and it's a great honor to be back with you. Also, at least one of the speakers this morning, Dr. Carruth, I don't know if she's still on or not. It was a great pleasure to work with her. So we have the slides up now, and as you see, I'm going to be sharing with you today some thoughts on global occupational medicine. I've had the privilege of working in many countries around the world, and have seen both the education side, the research side, and the clinical side of this work. Next slide, please. The father of occupational medicine is a distinguished physician by the name of Bernardino Ramazzini, who was born in 1633 in a small town in northern Italy, in Carpi, where the collegium that Dr. Levine mentioned meets every week. And he wrote the first textbook in occupational medicine in the year 1700. There had been prior efforts at looking at workplace health. There was a study in 1556 looking at the health of miners in a book called De Re Metallica on the use of metals, and but it was not devoted to that and had only a small section. As many of you appreciate, the field is now called occupational and environmental medicine, but the environmental piece is a relatively recent addition, only a few decades old. It was realized that hazardous materials left the workplace. They came home and affected family members. They didn't stop at the factory gates. They didn't not go out in the water supplies, so that we realized that environmental exposures, as we've heard from some of the talks today, are important. Next slide. The field of occupational medicine has often not been part of clinical medicine training, both in the United States and globally. There is very little training that any physicians anywhere in the world get in this field. That really is rather astonishing, considering here in the United States at its peak, we had over 160 million Americans working, full or part-time. We have everybody who lives in some environment that includes air and water exposures, but we do very little training in medical school in this arena. Next slide, please. There are some generic issues that apply literally all over the world. This has to do with both workplace and worker assessments and how they fit into regulatory issues. Occupational physicians work very closely with other safety and health personnel, particularly with industrial hygienists who measure the workplace. And I have a great deal of respect for industrial hygienists, but at the end of the day, whatever the regulatory amounts are and whatever the workplace measurements, until you actually do worker assessments, one does not know if the workers are being protected by the measurements that one gets and the regulations that are in place. I've already touched a bit on training and manpower, and we'll go into that in a little bit more detail, but there is pitiful little training and not nearly enough manpower. Here in the United States, as studies have been done nationally, the single field of medicine with the greatest shortfall between what should be in place in terms of manpower, person power, and the actual existing stock of physicians is the field of occupational medicine. And then there's also the issue of research. We've heard some wonderful talks from the residents today. I want to commend them. But research is also an area that is not greatly supported. Next slide, please. So activities that are related to the workplace and worker assessments are really pretty universal. When occupational medicine is done, measurements are generally taken at workplaces and workers are judged as to their fitness to work. And in some countries, occupational medicine is little more than making sure someone's fit to go into a certain kind of workplace without much follow-up. And as I've noted before, we now have added environmental issues, and those have been particularly added to our understanding and work in our field, both in America and in Europe. And we've actually changed the name, even though the boards in our field are still called occupational medicine. Our main college, the American College of Occupational Medicine, has become the American College of Occupational and Environmental Medicine. And journals quite regularly have added the environmental piece to their working titles. Next slide, please. We heard from Dr. Patel earlier this morning some of the data with regard to Texas and the work that she does in looking at injuries. You know, 2% of workers will get injured. There are 500 plus deaths a year in just the state of Texas. But when one looks at the data that I have up on the slide right now, it's really quite staggering. If you look at workplace safety and health, it's been estimated by international agencies that look at this, that there are 100 million yearly injuries related to work and 100,000 deaths related to workplace activities. Those are staggering numbers. And in terms of disease, which are not necessarily as acute as injuries, but can be deadly nevertheless, there are 11 million disease developments on a yearly basis and 700,000 disease deaths. We still have a large number of deaths in this country from some of the topics that have been mentioned, like asbestosis and silicosis and workplace related cancer. So in terms of the world, it's a pretty staggering problem that we don't pay enough attention to. Next slide, please. We've heard a bit today about agricultural safety and health, and farming is still the most frequent job in the world. Many farmers are nothing more than subsistence farmers. They're taking care of themselves and their families, maybe raising enough to sell a bit or trade a bit. And we should also note that the demographics of the world is changing, that at present, it's now been estimated that at least 55% of the world's population lives in cities, and this is rising. And certainly in some countries, the number is even much higher. Yet with this, only about 15% of the world's population live in developed countries. And so much of this is data that applies to other major segments of the world: Asia, Africa, and South America. The next slide, please. While we usually think of agriculture and mostly we think of farming, having been involved in my days at Tyler with the Southwest Center for Agricultural Safety and Health, one comes to know that it is not only farming, but ranching, forestry, and fisheries that are part of the larger world of agriculture. And certainly in one of the neighboring states, in Arkansas, forestry is a major industry. Ranching is certainly big in places like Texas and Oklahoma, New Mexico, where the center did work. Farming is ubiquitous around the United States. And Dr. Levine and his colleagues who have been looking after the Southwest Center have taken on an area that has very little work being done in the United States, even very little in the world, and that is looking at the effect of fishing on safety and health. So I have a note there that a notable exception to the lack of work in this area is the work at Tyler, one of only about a dozen major entities in the United States that is interested and does significant work in the field of agricultural safety and health. The next slide, please. In terms of where occupational physicians work and the folks that assist them, there are a number of individuals who are physician assistants and nursing personnel that go into occupational settings. Traditionally, the most common site is to work for companies. Some work for government agencies. Academics and academia in the United States is about 10% of occupational physicians. Some work at unions, some work at freestanding clinics, and even some NGOs will have staff that do occupational medicine and work in that arena. So there's lots of settings, but not a lot of personnel. Next slide, please. As much as physicians here in the United States will work in corporate settings, it is even more true in the rest of the world by and large. I've got some data from a couple of countries coming up. but the vast majority of physicians that do occupational health around the world will be stationed at medical departments at the companies and working in those settings. In some ways, that obviously makes sense. That's where the workers are, but there still is a need for academic pursuits, research, and to train additional physicians. Next slide. There is a much longer tradition of occupational medicine in Europe. As I said, Ramazzini wrote the first textbook in 1700. Certain hospitals were developed in Europe, in Italy, and other countries, literally devoted only to workers. They take in workers with diseases that are thought to be related to work. There's a little bit of such entities, if not hospitals, at least clinic settings. I've run into one in Mongolia. There's a clinical operation in the capital in Ulaanbaatar where workers literally from around the country can be sent there to be assessed for workplace exposures. There's little training in the developing world, however, for developing knowledge about occupational medicine. Next slide, please. As I've commented a number of times already, medical education often contains little occupational medicine training. In the United States, when one looks at the medical education of physicians, again, even though we have everybody living in an environment and half of the population of America working, the average amount of time at medical schools in the United States for training in occupational medicine is generally about 4 hours in 4 years. Much of that is even devoted to pathology, where things like black lung or asbestos-related diseases get talked about, lead poisoning in pediatrics, and not much else. As I've traveled around the world and looked into medical education, there's really not much education in this field in other countries. Next slide, please. I've already mentioned that it's the greatest shortfall of practitioners in this country and around the world. Next slide, please. We certainly don't have enough occupational physicians in this country. Only about 2/3 of all medical schools have somebody on the faculty, either full-time or part-time, that is trained and can teach in occupational medicine. 1/3 of schools really have no such training. But then as I've looked around the world, in a country such as India with 1.3 billion people, hundreds and hundreds of millions of workers, there is only about 1,000 doctors in the whole country that do occupational medicine, and many of them have had fairly limited training. There's a 3-month what's called a certificate course over there that a doctor can take and then be qualified to be called an occupational physician. In all of India, there are about 100 industrial hygienists, clearly not enough. Sri Lanka, a nearby country to India where I've worked, there are less than 10 doctors in the country that are trained in occupational medicine. 2 of them at one point were working at the equivalent of NIOSH in Sri Lanka, and a few companies had doctors that did occupational medicine. But this is a country of 20 million people with virtually no workforce in the area. Next slide, please. I've already mentioned that part of what we ought to be doing is research in occupational medicine. This is really often an afterthought. If it wasn't for centers like at Tyler and for residency programs, of which we have a dwindling number in the United States. Again, occupational medicine was a very small field with a dozen or so programs, let's say in the 1950s, with some funding from the government. It grew. At its peak, we had something around 42 or so occupational medicine residency programs. We're down now into sort of the low 20s, I believe, in terms of the number of residency programs. and the number of doctors that are turned out each year is quite minimal, somewhere around 100. That may not even be replacing people such as those of my generation who are reaching the end of their working careers. And we probably are losing as many doctors every year out of the field as we are training. Notable is that it's only at a few places that research is being done, often with very modest government funding. Next slide, please. In the United States, some funding comes from NIOSH, some from OSHA for training of workers on the front lines, not a whole lot from the CDC, though they do fund and look at some environmental issues. Here in the United States, the amount of money allocated for research for workers and exposures is somewhere around 10 cents per worker, probably a bit less than that now from when I last looked. In places like Scandinavia, where they do significant amounts of work, it is probably on the order, the equivalent of about $3 per worker in those countries. So some work gets done in Europe, particularly in Scandinavia, Finland, some work in Germany, not much in other countries. There's a couple of units in Poland. South Korea has a number of people. China has a couple of universities and a couple of health units around the country, but for another country with 1.3 billion people, there is really very little research and very little that ends up in the scientific literature. Next slide, please. So having set the stage of where the field has come from, what it's, how it's developed, the shortfalls that we have, let's talk about a number of issues about occupational medicine and related fields. If somebody would come to me now and say, as someone who's devoted many decades now to occupational and environmental health issues, what is the thing that concerns me the most from a health standpoint? As you see there, number one is climate change. I know we tend not to think about that as a medical issue, but it will have enormous impact upon not only workers, but all of the people that we look after and care for. In the part of the world that you can find Texas, for example, not too far away in Colorado, they're fighting over the waters of the Colorado River, who gets the water from there because it's going to run short. We have Johannesburg in South Africa that was down to rationing small amounts of water for individuals each day. We had Chennai in India, again, a city of many millions of people that was running out of water and doesn't have enough supply to take care of people. So we're starting to see in some places this effect of lack of sufficient clean, healthy water for people, and that's going to be a major problem. The earth is going to get hotter, agriculture will change. Things that now can't grow in northern climes will be able to be grown there. It's going to change the amount and number of pests that we see, the lack of truly cold winters that normally would kill off pests that overwinter in trees and other places will not occur. And so the devastation of pests in our society is going to increase. Deserts are going to increase, and growing seasons are going to change dramatically. And, you know, if I can make an analogous point, just as we see many people here in the United States deciding that wearing a mask might for them be a political statement or something they just don't want to do, we don't see the world coming to grips with the idea that we can't allow the continuous heating of the world. But to move on, we're also going to see issues of employment and underemployment. The whole nature of work in this country has changed. The kind of part-time or so-called gig workers that we have is markedly different from what has existed in the past and is only likely to increase and make issues of health insurance tied to employment or just having enough money to support yourself going to change. Around the world, there are two other issues that are quite significant. One is that of migrant labor. We see that in, especially in poor countries. When they locked down India recently, we saw that the migrants who have left these small villages in rural India to go to the big cities and literally were day laborers living day by day, paying for food with whatever they earned that day. When work was shut down, they attempted to go back to their villages and suffered greatly on the way and had to be fed literally by the kindness of strangers as they tried traveling as much as 1,000 kilometers to go home. The other problem we see in parts of the world, again, places like India, where I've spent more than 24 visits over the last couple of decades, is there's still a major problem with child labor. Here in the United States, it's not a big problem except in one sphere, which we did study when I was at Tyler at the Ag Center, and that was farm labor. Children as young as 2 or 3 are raised in a farm setting and may go out and collect the eggs from the hen house. And we were really rather shocked when we learned that in some farm settings, children as young as 4 or 5 years old were asked to go out and drive tractors, pieces of equipment that certainly put them at risk. So there are very large issues of work and our environment that are out there. Next slide. Why has this become important, especially in looking more globally and outside the United States? We always hear about how companies have moved their operations out of America. You know, in Texas, we know that across the border are the maquiladoras in Mexico. But if you look around the world, our textiles now come from Asia. Sewing gets done in places like Turkey and parts of South America. And why do industries move? Well, on the push side, they claim that there are regulations, both of the workplace and in the environment, environmental regulations. And they claim labor costs are high. Obviously, workers living in the United States doing similar work need to have a living wage. We certainly don't have enough people yet with a living wage, and even the $15 an hour that we talk about nationally for a lot of people would not easily support a family of 3 or 4 people. What's the pull factor in addition to the pushes? Obviously, the other side of that, less regulation, cheaper labor with unemployment in a lot of countries, a huge labor pool that they can take advantage of, shortages of hard currency. And in many countries, companies are encouraged to industrialize the nations that they are moving to and help with that. So there are benefits being given to companies literally to move. Next slide. So we've already talked about some of this. The climate change will bring about changes in pests, water shortages, heat issues, air pollution. We just had a talk on a death from heat stress, heat stroke. We're going to see more of that. We've been seeing that over the summers in the last decade or so. Chicago, France, other parts of the world. Clean water is going to be a problem. The provision of even basic medical care is still a difficult issue in this country. We have issues of radiation exposure that I'll be speaking about, and reproductive hazards. We're putting chemicals out in our environment that are endocrine disruptors and are proving to be a problem. We heard something about PFAS and pesticides already today. Next slide. Some of these are the same issues that we heard from Dr. Patel earlier about occupational lung diseases, things like exposure to coal and silica and asbestos. A major new issue that's come to the attention of the American public and probably needs to come to the attention of physicians more than it did is asbestos contaminated talc. That is an issue as well. We're learning that talc that people have used, literally for 100 years in this country, likely has had significant amounts of asbestos, and we're learning that mesotheliomas and other diseases have occurred because of that. Some of the work that I've done in India has been looking at the talc, and this is a country where hundreds of millions of people use talc on almost a daily basis because of the heat and humidity over there. And we did a study published last year that 7 out of 13 samples were heavily contaminated with asbestos. We've heard about pesticide use. I'm going to comment on that a little bit. Radiation, we're going to talk some about each of these issues. The relationship of workplaces to primary care, ergonomics, which means person-machine interactions, injuries, which we've talked about, hearing loss, and then occupational eye injuries, which were mentioned by Dr. Patel. And then an area that is getting increasingly important is occupational health psychology. So next slide, please. So I've already mentioned the talcum powder issue, but as much as we think we know about, let's say, silica exposure, which is hundreds of years old in terms of causing disease, we learn out of Turkey, for example, that as people want their denims to be modulated in terms of their color, they stonewash them, they put them in with silica and wash the color out, and the workers doing that end up getting silicosis. The same thing for jewelry polishing. And another major new problem talked about in as diverse places as Australia, United States, parts of Europe, Israel, has been artificial stone countertops. They're 97% silica. They're material that's put together with glue. They're sanded. Workers often don't take precautions. And so we see new ways in which silicosis develops among individuals. Next slide, please. We have environmental lung diseases. Asthma is a continuing problem. Lung cancer is not only an occupational problem, but we still have the problem of cigarettes. We have the problem of radon in some places. And then environmental asbestos exposure is something we're seeing more and more of, going back to my earlier comment that materials leave the workplace and go home, or simply living near a facility. We have a famous one in Louisiana, near New Orleans, a big asbestos plant in a place called Moderator put out significant amounts of asbestos into the local communities, getting people sick who didn't work at the plant. Next slide, please. Pesticides are also a problem. We've heard some of that earlier today. I don't know how many of you picked up in the last day or two the glyphosate issue that has been nagging at this country. Is it a carcinogen? Is it not? The company says it's not. A lot of data shows that it likely is. There is, as of yesterday or the day before, an $8 billion proposed settlement by the now owners of the glyphosate material, Bayer, who bought up Dow Chemical, to settle thousands and thousands of lawsuits, perhaps recognizing that the data is what the data is, and they've been losing cases. We also learned that more is not always better. Some work I did with colleagues in Egypt some years ago, or I was there doing some work, and learned that crop yields in Egypt were being increased by the use of pesticides. And so farmers started using more and more and more pesticides, thinking more was better, never being educated about their proper use. And all of a sudden they found their crop yields actually going down. What they then learned was when they cut back on pesticide use from about 300,000 pounds a year to 30,000 pounds a year, a tenth of it, their crop yields went way back up again because it was the optimal use, but no one was there to educate them about optimal use. Malevolent use is made of pesticides as well. In India, it is estimated some 10,000 or more farmers a year commit suicide by taking pesticides. And we always have in the United States a number of pesticide-related deaths each year. Next slide. Radiation has become an issue that we once thought was only related to atomic weapons, and we learned a bit about radon, but we know about catastrophic potential outcomes now, Chernobyl, Fukushima. There's some health studies ongoing. Some colleagues at the University of Colorado School of Public Health have been training their health physicist students to look at issues at Fukushima, not only in people, but in the animals in that region, finding that they are heavily contaminated. So there's some interesting work in that arena. And what we still haven't mastered in this country is what do we do in terms of the waste generated from nuclear power plants, which are certainly clean and would help with the issue of climate change, but we haven't solved the problem of waste disposal for that material. Next slide, please. Healthcare is something that we've gotten better about in this country, and there are many European countries that pretty much have universal healthcare. It is certainly still not something you see around the world, but one thought is combining primary care at workplaces. We've done a bit of that here in the United States. Some companies do that. That's probably an area we should think more about. We certainly could see that overseas. There are many companies where they employ literally, thousands of workers at a time. And if they set up a clinic and took care of not only the workers, but their families, it would strengthen the provision of primary care. Also, that would allow for some understanding of environmental health issues in some of those countries. Next slide, please. And it would get to this issue as I've been talking of providing basic health care to all. Next slide. Ergonomics is something that we've better appreciated as an area of concern over the last couple of decades. The biggest one, of course, we see in many states that the majority of workers' compensation claims come from musculoskeletal problems, and many of those, in some cases, most of those come from the use of computer screens and keyboards at offices. We're now able to telecommute. I'm, giving this lecture sitting at home because I haven't been going out. I'm pleased we're able to do that, but the world has certainly changed. And yet I'm spending a lot of time on my computer as people do at work. And so ergonomic issues, and then in other manufacturing settings, especially where items are being built in automotive construction and other areas where we need to pay more attention to ergonomic issues. Next slide. Next slide, please. We heard from Dr. Patel that in Texas there was some interest in hearing loss. That is a very common problem related to work. It's certainly a common problem in older people in general, but work has a lot to do with it. But we also know that there are other circumstances in which hearing loss can come about, and we need to think about those issues. Again, in India, they have a yearly celebration of, it's called Diwali. It's their biggest holiday. They sometimes say it's like their Christmas. It's usually held in the fall. And again, just as we've been hearing on the news the last few days of people being stuck at home and setting off fireworks and firecrackers in all kinds of settings prior to the 4th of July, this is a big deal at Diwali. And literally, hearing loss results in many people, not to mention the hazards of setting off explosives of various kinds that have done damage to life and limb. We also know that hunting or rifle use and motorcycles is another source of hearing loss. The next slide, please. I mentioned earlier that an underappreciated area and an area without much personnel is that of occupational health psychology. There are only a few programs in this country. Probably one of the most prominent, again, is the University of Colorado. Vanderbilt's had one. I think there was a program in Alabama. One of my colleagues at Drexel is looking into these kinds of issues. But we have not fully appreciated the psychological aspects of work. My colleague at Drexel looks at first responders, particularly people in the fire service. And one of her areas of interest has been EMT workers. And one would be horribly surprised, I think, to know that EMTs are often put upon in communities or by the people they're trying to help. If you've got somebody who's mentally unstable at the moment, if you've got communities where firefighters are not generally welcome, they will attack the EMTs, and a very high rate of injury in the fire service comes from EMTs being attacked, and what that does in terms of setting up things like PTSD and so forth. We've seen this problem elsewhere in China. We've seen suicides at these large factories where workers do repetitive work. Last year I was in India. I was asked to come visit a steel mill and look at their occupational health programs. They asked me to give a talk. And when I asked what is it they wanted me to talk about, having made a few suggestions, one of them was not on occupational health psychology. They said, what we really would like is a talk in that area because we see that as an important problem. And they brought about 200 of their safety and health personnel together, and we spent some time talking about psychological issues at the workplace. Next slide. We have spent some time already today, and we're all doing this virtually instead of being together. I really missed the opportunity of being with Dr. Levine and my colleagues in Tyler, where I had many good experiences and would have loved to have been with you in person. But we have a pandemic now that has changed the whole face of the earth. It is not just the United States. It is virtually every country in the world. As bad as this virus is, fortunately, it doesn't seem to be as virulent as the 1918 flu epidemic was in its day, but we still haven't mastered it. And the world is a lot more dense now than it was then. And so it's a major problem, and it's personally to me upsetting as a person who's worked in public health and prevention his whole career, that we, months and months into this, see half the states in the United States in worse shape now than they were previously. And what we've learned so far is how to deal with bringing the rates down, but many people are not willing to buy into that. There was just a paper I read yesterday that in those countries where masks are diligently used, they have a much smaller problem with the people getting sick and transmitting things. Next slide. There are international organizations in occupational and environmental health that look at workplace and environmental issues. The World Health Organization in the area of cancer. We have IARC, the International Agency for Research on Cancer, part of the World Health Organization. International Labor Organization, the International Congress of Occupational Health, the Collegium Ramazzini. So we do have some national organizations, but they tend to have really no clout, and they are more by way of recommendation than being able to do very much country by country. Next slide. There are relatively few countries that assist others in this field. The Finns and the Scandinavians are particularly good in sending people around the world and making collaborative efforts. I hate to say this, but I've been in this field since before OSHA got started. The United States used to be the preeminent scientific leader in occupational safety and health issues, decades ago. We are no longer in that position. We give little help around the world in terms of that area or others as well. So while there's still a great need elsewhere, ours is not a country that has been supportive of this. And we really do need to think globally when it comes to issues like protecting people's health and protecting our environment. Next slide, please. There are a number of international journals in this country, Europe, Asia, and elsewhere. And not only do I read the occupational medicine journals, but as an internist, I read some of those journals as well and occasionally publish there as well. And there are good journals and bad journals. And good journals are ones that have earned over years, decades, maybe even centuries, their reputations for high quality reporting. It's hard to get your papers in there. They've come under a little bit of criticism because they're trying to publish COVID articles pretty quickly these days. But there are truly some what I would call bad journals that one has to be aware of and concerned about because they provide an access to people who have agendas other than people's health and well-being to publish their research. And they do exist, and in our field, people need to become aware of which journals are reliable and which ones one has to read with a bit more concern. The next slide. This leads into the question of ethical challenges in our field. We have ethical challenges in areas like the EPA in this country at the moment. In my own state now of Pennsylvania, where I serve on a board at the Department of Environmental Protection for about 14 years. I've been on the Environmental Justice Advisory Board, about 10 of that I was chair. Just today, a report came out saying that people who have been harmed, their water supplies and such, been harmed by fracking, have been getting short shrift by the DEP. So government agencies don't always respond like they should. In India, with the government they have now, they want to set aside environmental rules and regulations to encourage businesses. And then we have things like the Rotterdam Convention. This is a body of 129 nations that meet about once a year, and they have a list of chemicals that are considered especially dangerous. And they can in no way block the use of those chemicals or the manufacturing of those products, but they can list them so countries are aware. But it has to be by unanimous vote of 129 countries. So on occasion, one or a handful of countries, literally no more than that, have blocked what everybody else in the world thinks is an especially harmful problem. We have corporate entities that are a problem, and I've dealt with this in India. I once was scheduled to give a talk over there, and they were so upset about me giving a talk because asbestos work has been a large part of my life's work. They were threatening to sue me for $50 million. I told them I didn't have it, so it didn't really matter to me. And then, we talked about the pesticide issue, and then, we keep hearing stories about pharmaceuticals and the opioid crisis, again, being a sort of an ethically challenged situation. There's issues of science for sale, companies buying the science they want. And at its worst, we have corporate spying, which has occurred and has affected people I know and even myself. Almost done. Next slide, please. We have a number of legal issues in occupational medicine, following rules in the workplace. We have companies that work very hard to fight compensation issues that are pretty straightforward. We have governments deciding on the basis of poor science who should get or not get compensation. They leave out certain groups from compensation activities. And environmental regulations are even harder to enforce, and governments often wish not to do that. We see that in this country, we see that in India, we see that in many other places. Next slide. So, in conclusion, the provision of high quality occupational medicine services needs to be improved worldwide. And the next and last slide, I think that all physicians and healthcare providers should better understand the interactions of work and health and the environment and health. And I'm so pleased to be a part of a conference such as this that aims to do that, to be connected even peripherally and from a distance with residents at Tyler. There's also the program in Houston and a few other programs around the country. And we certainly need more of that. So thank you for your attention. I think we still have a bit of time for some questions.
Well, thank you, Dr. Frank, for a really great presentation and a glimpse into what is happening on a worldwide basis. For those who don't have the background and experience that you do, it's quite fascinating to see what's happening in so many places. And I'm sure this is an issue abroad, but while people are putting questions down, one thing that came to mind was something that our two programs had an opportunity to participate in several months ago. Was a viewing of a documentary called American Factory that actually won an Academy Award, a documentary Academy Award not too long ago. That was about the purchase of a closed automobile manufacturing company in the United States by an international buyer. And the gist of this background is that it actually was refurbished into glass manufacturing in Ohio. That's where the plant was. And was a lot of focus on collective bargaining and safety and health and that sort of thing. So my question to you is, for now, just looking at the US, what directions do you see as it relates to occupational health in terms of how that's changing, maybe the issue of robotics, and what role, if any, something like collective bargaining will continue to play in driving the protection of the safety and health of workers?
Thanks for the question, Jeff. There are really two sides to that. One is the robotics issue, and it's not only the robotics in plants, but self-driving cars. Uber's going to do without drivers. Self-driving trucks that are going to they've estimated in the not too distant future, 40,000 truck drivers out of business. So we have to think about how are we going to deal with that. Those kinds of activities do make the highways safer. It does make plants safer if a robot does hazardous work like welding or maybe painting, so people don't get exposed. But we still have to figure out what to do so people are employed for so many reasons. One, for people's self-worth, for simply having a paycheck so you can live and raise your family. The collective bargaining issue is the other side of that. And I'll make an observation first. When I started in this field, a number of decades ago, about 35% or so of all workers in the United States were unionized. This covered most of manufacturing. It covered everything from places like the Newspaper Guild, coal mines, government workers. We're now down somewhere around 10 or 11% of unionized workers. Most of those, not all, but most of those are now in either government or service capacities, very little in the way of manufacturing or those settings, construction, those settings where the risks for injury and exposures leading to illness are the highest. We also have, if one looks at the economics of the world and of the United States over the last couple of decades, basic wages for most individuals have not risen. People are not especially better off now, and in many, many cases, we see people dropping out of the middle class, going lower on the economic totem pole. And so I think unions, as much as they would like to fight for safe and healthy workplaces, probably have to put two other things before that. One is their own survival as unions, making sure they can keep members. And the most important issue to a member is the paycheck that he's going to get. And what we see, and we've seen with the pandemic, we've seen it with healthcare personnel, we've seen it with so-called essential workers, like those that work at Amazon warehouses and supermarkets and things. For at least a period of time, they've been paid hazard pay, extra pay because of the hazard. If they made workplaces safe, if they didn't have the meatpacking plants with 500 people out of a couple of thousand getting sick, if you put in proper PPE or just simply slowed the line down so that you could spread the workers out. Again, as much as noise is made about it, folks are not fighting as they used to for safety and health issues, because the very basics of I need a paycheck has become much more important. That's at least from my perspective.
So we have two other questions in our time remaining. One comes from Dr. Perkison, who's the program director at Houston. You probably know. He says, any thoughts on how to approach working with ACGME and the U.S. Congress on increasing the number of residency positions in occupational medicine?
That has been a classic problem my whole career. I've been in charge of a number of residency programs. I've started a number of residency programs. I think the easiest fix, because we still don't have a Congress that, for all the talk about prevention, really puts their money where their mouth is. The easiest and quickest fix, I think, would be to get occupational medicine residents covered under Medicare, just like every other kind of resident is, except for those in the field of preventive medicine. That would bring more money in, and then hospitals would be encouraged to start occupational and preventive medicine programs.
So I think we have time for one more question, which comes from Dr. Eloise, it appears. So he says, any suggestions? He is our DIO here, I think you know, Dr. Frank. Any suggestions on how to increase education and skill set of all medical students and residents in occupational and environmental health?
Oh, I'm getting nothing but these really softball questions. Yeah. Again, I've been part of medical education my whole career. I've worked at 4 universities. The problem is that occupational medicine is not now in the curriculum. They keep shoehorning more and more stuff into it. I have my older son is a physician, and when he went to medical school much more recently than I, had a lot more to learn than I did. And to ask to put in some occupational and environmental health issues becomes very problematic when you're competing with all the other issues that people have to learn. I think the way to do it is to work with our colleagues who want to train internists and family practitioners and emergency room physicians and pediatricians to focus on including more into their medical education curricula at the residency level, because I don't think you're going to get it into the medical school curriculum time, so that internists learn to do the one thing that Ramazzini suggested: ask of your patients what they do or what they did for a living. I look at hundreds of charts a year and I see that question never being asked, or, employed and it says retired. Very unhelpful. Pediatricians should learn about not only lead poisoning, but endocrine disruptors. OBGYNs should learn about those. I think that's the way to do it. When I was at Tyler, I actually worked with the family practice people in a national effort to increase family practice doctors, adding OEM material to the residency curriculum. That's probably where it has to start.
I think we had another question from Dr. Christia Swagwu, but it does appear to focus on some of the same things that you've just answered, in particular, how to get one of the best kept secrets out, and how to integrate that perhaps into medical education and residency. So with that, we are coming straight up at 1 o'clock. Dr. Frank, must have my president on the mind for some reason or another. Thank you so much for at Grand Rounds, for being a part of this. We're certainly looking forward to our ongoing interaction with you. It's been such a delight, such a pleasure. The one thing I've really not liked about the virtual world, among some others, is that we don't get as much of an opportunity to, in a congregate way, applaud you for your presentation. But please know that I think everyone on this conference today have really taken a lot away from all the presenters and from this grand round. So thank you so much.
Thanks very much, Jeff. Thanks for the honor of being with you again.
So just for all the conference attendees, this brings us to the conclusion of today's Emerging Issues Conference. I hope it's been of value to you. We've tried to get to most of the questions that were in the question and answer box. Let me just again encourage you, if you will file your evaluations using the QR codes along the way. But again, if you are unable to do that, you'll be subsequently receiving an email based upon your registration that will allow you to link later on to complete your evaluation for CE credit. And then again, as I mentioned, this is being recorded and it will be available subsequently as well by an email link. So with that, I'd like to thank everyone today for their attention and their participation and attendance at this biannual event. I'm looking forward to the next time around. And again, my special thanks to all of the people who worked so hard to bring this conference together. With that, that concludes our Emerging Issues Conference. Thanks again, and stay safe.